Oh, I didn't see you walk over here and do it. I probably just turned it off. Your mic is on. All right, everybody, it's 6 o'clock. You know what that means. It's time for YSU Trumbull Regional Medical Center Combined Refresher. Appreciate everybody spending their time with us tonight. I also appreciate when you get signed in early and signed in on time. Up on the screen, you're going to see a flyer from Trumbull County Mental Health Board regarding racial injustice, suicide prevention, and mental health. If anybody is interested, I have 10 free tickets for this event. All the information is up there. You can scan the QR code or email me if you're interested. I'm going to be going to check this out. It seems like something these days we could really use in our toolbox, maybe some negotiating tools. So if anybody is interested in that, please get a hold of me. Tonight we have a lot of Joe Mistovich.
Oh yeah,
that's a good thing. We're going to be talking about endocrine emergencies, and what else, Joe?
Anaphylaxis, anaphylactoid.
So that's going to be a great talk. I'm looking forward to that. So in the interest of trying to get us started on time, to maybe even get out of here on time, we'll see what happens. Here's Joe.
All right, thanks, Matt. All right, let me see if I can do this. I'm gonna learn this, probably on the last day. I'll get it down. All right. Wait a minute, that's not the right one. I want this one. All right, this is the one I want. Okay, so this is what we're going to talk about, and I think the key tonight is what's the first word, understanding. And some of you are probably going like, oh God, I've dealt with these diabetic emergencies for so long, but I think there's still a lot of misconceptions around the diabetic emergencies. But one of my keys, that I want to try to accomplish tonight is actually that you understand it, and especially, especially for any of the EMTs out there, or advanced EMTs, and even some of the paramedics. I've actually done this lecture pretty much all over the country, and I've had nurses that have come up to me and said, I've been a nurse for 20 some years, and this is the first time I really understood this, So I'm hoping that, this does make more sense to you. It no longer requires you to try to memorize signs and symptoms. You understand the signs and symptoms, and also the treatment, but I think also the severity and criticality of some of these conditions too, and completely understand, why you're treating the way you're treating, and some things for you to look out for. So with that, I'm just going to go ahead and plow right into it. And if anybody has any questions, let me know. This is like, Matt had said, and Larry previously, it's, there are things that we do have to cover as part of the National Registry's NCCP program, and this is part of that, and also the anaphylaxis. So, and a lot of the components in this is what needs to be covered. So, all right. So, if you can understand these terms, then a lot of this is going to make complete sense to you. Complete sense, because if you can just look at the term, in some of these cases, you look at the disease name, it's going to tell you exactly what's happening, the pathophysiology of the actual condition that the patient actually is experiencing. So, and we start with the term diabetes, and I would venture to say that a majority of the people, when you pose this to them and say, well, what does the term diabetes or diabetic actually mean? And I would venture to say that a lot of people would respond with, well, it has something to do with control of sugar. And, and I've done this in, classes again, all over, and in my own classes, paramedic classes, EMT classes, more so the paramedic classes. The EMT classes too, those students would say, well, that's obviously somebody who has trouble controlling the sugar. Well, I'm here to tell you that the term diabetes actually has nothing to do with sugar. And this again is important when you start looking at these conditions. Anytime you see the term diabetes in a medical name or referred to in a medical condition, diabetic diabetes, in the Latin term, it means to flow freely or flow through. And so if you looked up diabetes in a medical dictionary, what it actually means is an increase in urine output. It has absolutely nothing to do with sugar or glucose. So anytime you see the term diabetes, don't think sugar. The first thing you think of is, here we have a patient that actually has a condition where they have an excessive amount of urination. From what we don't know yet, that's the other part of the condition. It could be due to glucose, or it doesn't necessarily have to be due to glucose, but that's what the term means. Now, the term mellitus, because the diabetic patient who has trouble regulating their glucose is referred to a diabetes mellitus patient. We commonly just refer to them as diabetics. That's actually erroneous. They're really diabetes mellitus patients, because if you just said they're diabetics, all it means is they're peeing a lot. But if you say they're diabetes mellitus patients, that means then they have an issue with glucose and glucose control. So mellitus means sweet, or sweet, basically sweet tasting. So the actual condition of glucose control is diabetes mellitus, and it's abbreviated by DM. Okay, so just to get that straight. So then there's a condition. So this is just to prove a point that, so we have people out there that have a condition called diabetes mellitus. And so if you get on the scene and you say, well, okay, what seems to be the problem today, and and you got this patient, looks like they're dehydrated and so forth. And you say, well, what's your medical history? And they say, well, I have a history of diabetes insipidus. And you go, oh, well, okay, let's check his blood glucose level. You don't need to check the blood glucose level on a patient with diabetes insipidus, because diabetes insipidus has nothing to do with glucose, has nothing to do with insulin, has nothing to do with the regulation of glucose. There's no reason to check the blood glucose level. Diabetes, again, means an increase in urine output. And again, the term mellitus means sweet. In this case, insipidus means tasteless, basically, in the old Latin terminology. It means tasteless, almost like clear, tasteless type of fluid. And so if you say, well, okay, so we have a patient with a condition called diabetes insipidus, then it has nothing to do with glucose, but what it's inferring is that the urine is tasteless, and it's clear, meaning that it doesn't have glucose in it, but there's a large amount of urine that's being produced. Well, this is a condition actually that's associated with the inappropriate secretion of, or actually inadequate secretion of antidiuretic hormone. Antidiuretic hormone secreted by the posterior pituitary gland is what actually keeps you from urinating. And if you don't secrete enough of antidiuretic hormone, you are going to urinate excessively. So these patients have an excessive amount of urination due to an ADH issue, and has nothing to do with glucose. But here's what I'm going to tell you. Anytime you encounter a condition with the term or the name diabetic or diabetes in it, the first thing you have to think of is excessive urination. And if there's excessive urination, what are you going to start looking for clinically? Signs and symptoms of dehydration. So you're going to start looking for all the signs and symptoms of dehydration: the dry skin, the dry mucosa. Well, in this case, you're going to have a patient with an increased urination, but if they're so severely dehydrated, they're going to go from polyuria to oliguria, meaning they're going to have very little urine output now, but you're going to see severe signs and symptoms of dehydration. You're going to find tachycardia. You're going to find relative hypotension. You might find a narrow pulse pressure. You might find some pale, cool, clammy skin, and so forth with the patient who is severely dehydrated. So again, I'm telling you, anytime you see a condition with the term diabetic or diabetes in it, start thinking excessive urine output. I don't know why, but I need to start looking for signs and symptoms of dehydration. And how do I treat the dehydration? It's actually very simple for us in EMS. at least at the advanced EMT and the paramedic level, and that is you start an IV line, you start giving them fluids, whether it be normal saline, lactate or ringers, lactate, whatever you have, an isotonic solution. You're not going to give them any glucose-containing solutions. You are going to give them an isotonic solution, with water and electrolytes. So just keep that in mind. Keep that term in mind. Diabetic means increase in urination, look for signs and symptoms of dehydration, treat them with fluids. Glycogen is the stored form of glucose in the liver, okay? So when you eat a meal, about 66% or 60%, about 2/3 of what you eat in a normal carbohydrate meal actually goes to the liver to be stored in the form of glycogen. So glycogen uses a anabolic process to actually build a molecule, coupling glucose molecules together to form a complex molecule in the liver called glycogen. So glycogen is the stored form of glucose in the liver, but it's a molecule product, or it's a multi-glucose molecule, okay? So then the next term, lysis, okay? When you lyse something, you split it apart. So anytime you lyse something, you split it apart. So if you lyse glycogen, you split apart glycogen by the process known as glycogenolysis. What that means is you take that multiple glucose molecule and you split it apart and you split it back into free glucose. Well, that free glucose gets back into the blood, and that free glucose then can be used as regular glucose, okay? The glycogen can't. Muscle glycogen can be used within muscle and so forth. Glycogen can be converted to lactate and be used eventually through a whole different pattern. But you got to take the glycogen in the liver, split it up, put it back into a form of glucose in order for it to be used primarily by the brain, is what you're most concerned about. Now, so anytime you see glycogen, it's referring to the stored form of glucose in the liver, and glycogenolysis is splitting that apart and putting that glucose back into the blood. Now, gluconeogenesis, gluco obviously means sugar, neo means new, and genesis is the creation of. So gluconeogenesis is the creation of a new sugar. And so what that means is you're taking things like amino acids, you're taking glycerol, you're taking fatty acids and so forth. You're taking fat, primarily one of the higher energy sources is fat, but you could also take proteins and so forth, and you could send them into the liver, and you could actually produce energy substance basically in the form of glucose. Okay, so gluconeogenesis is taking non-carbohydrate substances, primarily fat and proteins, but we're going to find in the diabetic patient it's going to be primarily fat, and it's going to send it into the liver, and it's going to create a new form of glucose. Glucagon, and I know, EMS typically carries glucagon. They took glucagon off the ambulances for a period of time, probably for about 10 years or so, and they put it back on. And you'll find that glucagon is used actually in a lot more conditions than one would believe. And we'll talk about that. But glucagon is used in the diabetic patient. But let me tell you this: so glucagon that comes in that typically the most common way I believe it's still carried is in a reconstituted form, where you have like a tablet, almost looks like a little Alka-Seltzer tablet in one vial, and you have a diluent in another vial. You drop the diluent, it's 1 ml. You inject it into the other vial with the tablet. You shake it up, you mix it up, you draw off your 1 ml, and that's what you give to the patient as an IM injection. It's a hormone. Glucagon is a hormone. The glucagon that you're drawing up in that vial it's a protein hormone. It's not glucose. There's no glucose in there. You're not giving glucose. But what you're doing when you administer that glucagon, which is a naturally occurring hormone in the body, comes from the islets of Langerhans, comes from the alpha cells. But when you give it, what you're actually causing the body to do is glycogenolysis and gluconeogenesis. So by doing that, you're taking the glycogen, forming glucose, taking non-carbohydrates, forming glucose. So when you inject a glucagon, you're not giving them sugar, you're giving them a hormone that causes the two bullets above to occur. Okay, so there's no sugar in it. It's a protein. It's a protein hormone is what it is. Okay, so that's glucagon. Poly, we know, means many, a lot. So polyuria means a lot of urine. Polydipsia means a lot of thirst. And polyphagia means a lot of hunger. So if you ever heard the 3 Ps, these are 3 Ps they tell people to always look out for. You know, hey, if you're drinking a lot and you're peeing a lot, you know, and you're thirsty all the time and you're peeing a lot and you're hungry all the time, you know, you're likely, you better get your blood glucose, your A1C checked and so forth, because there's a good chance you're a diabetic. So, and we'll talk about the 3 Ps because those 3 Ps are extremely important when we talk about patients with high blood glucose levels in the field, okay, and things that you need to recognize too. You know, here's one thing I want to point out very early is there are a lot of cases, there's a high percentage of cases where you in EMS are the first people to actually diagnose, in a sense, you're doing a field diagnosis, and the diagnosis has to be verified and so forth. But you're the first person that's picking up this diabetes mellitus in this patient through your care. And they may have called you just because they've been feeling ill for several days. And again, their first presentation to you is not going to be hypoglycemia. They are not going to be hypoglycemic. They are going to be hyperglycemic. You know, these, you know, and again, once they're diabetic and they're on medication, then there's a risk of them becoming hypoglycemic. But if you're going to be the first person finding this diabetic condition, it's going to be hyperglycemia. It's not going to be hypo. Okay. Hypo means low. Hyper means high. Osmolar is the movement of water across a semi-permeable membrane. Okay. So hyperosmolar is where you actually create a situation, usually by putting a lot of particles across a semi-permeable membrane. So if this is my membrane and I take a large amount of particles and I put it on this side, you make this side hyperosmolar, where now it wants to draw the fluid, the water portion, over. So if I move a bunch of molecules from here to here, I'm going to draw a ton of water from here to here. So we create a hyperosmolar state. And we'll talk about that in the importance of that too, because that hyperosmolarity is going to explain why they're urinating so much in the patient who has a high blood glucose level. Okay, so these terms are extremely important. Now, this is interesting here because we know in the old days, you know, I started working as a paramedic. I got my EMT in 1979, started working as a paramedic in 1981. And the experienced paramedics, meaning the old-time paramedics, will tell you, we didn't have glucometers. We had chem strips, and we were hot shit with those chem strips too. And what we did was we took a drop of the patient's blood, we put it on a chem strip, and then what we did was we had to then wait, I think 60 seconds or 90 seconds or something like that. Then we had to rinse it off. Then we compared the color on the side of the chem strip bottle to tell us what range the glucose was in. Well, before we had chem strips, the only way that in the old days they knew whether a patient was diabetic or not, they actually tasted the patient's urine, and what they were tasting for was glucose, because again, the patients with the high blood glucose level, the hyperglycemic patient, which again, if you become a diabetic, you're not becoming hypoglycemic, you struggle with hyperglycemic every day until you are being treated. And again, then you have the potential to become hypoglycemic. They actually used to have to taste the urine. And what they were tasting for was sweet in the urine, a sweet taste. Therefore, the diabetes mellitus, a lot of urine, and it was sweet, and that was diabetic. So I found this years ago and just thought this monkey was concerned that he's a diabetic. So he, now if your glucometer breaks and you don't know what the blood glucose level is, then the best thing you could do is have the newest person on the rig, have the person pee in a cup and hand it to them and have them swish it around, like, okay, here you go. Who's the newest one on the rig? That's you, Larry. Here you go. Switch this around. Pretend it's wine tasting. Tell me if it tastes sweet. Anyways, but that's truly how they used to test for diabetes. I don't know who had to be the residents that actually were the taste testers. So the patient with the true condition of diabetes mellitus, they're on a spectrum, okay? So the chronic condition. Now, let me tell you this. If you have a patient who's been diagnosed as having diabetes mellitus, they struggle every day to keep their blood glucose down. They struggle every day with hyperglycemia, not hypo, with hyperglycemia. They struggle every day to bring their blood glucose levels down because in diabetes mellitus, in the type 1, they don't have any insulin secretion or very little. And type 2, either the insulin is not effective or the receptor sites are not effective, whatever it might be. But they're struggling to get their blood glucose level down. They wake up and their blood glucose is high during the day and so forth. So they struggle. That's what they struggle with. Now, hypoglycemic events do occur, but they're rare. And hypoglycemic events occur because of the treatment of the hyperglycemic patient, whether it's they're taking insulin, whether it's they're taking oral hypoglycemics, whatever it would be, that's what's going to cause them to have a hypoglycemic episode. But again, if you get on the scene, you know, and it's so funny to me because, you know, you guys know this as well as I do. They used to do this all the time in our dental hygiene clinic, you know, at YSU. And they'd be like, oh my God, this patient passed out. So we checked their blood glucose level. They're not a diabetic. And we gave them orange juice. And I'm like, well, you know, if they have no history of being a diabetic and they're not taking any oral hypoglycemics, not taking insulin, there's no way in hell they're going to be hypoglycemic. I mean, it's not going to, I mean, can it happen? I'm sure it can, but that would not be something. But everybody thinks like, oh my gosh, this person, they didn't. Here's a fun fact for you. You are much more likely to have a syncopal episode, a vasovagal faint on a full stomach than you are on an empty stomach, okay? So you're a lot more likely to have a vasovagal faint on a full stomach than an empty stomach. What's one of the first things, you know, these people are saying, somebody faints in church, oh my God, did you eat today? Did you eat? Go get orange juice. Go give it. Anybody have candy? Unless they're a diabetic patient taking insulin and they didn't take their insulin right, they're hypoglycemic, has nothing to do with it. And the reason for that is because when you have a lot of food in your gut, the parasympathetic nervous system is hyped up because it's sending all that blood to the gut for digestion. And that's why it's so much easier to faint on a full stomach than on an empty stomach. But anyway, so these are two ends of the spectrum. You have the emergencies that you're going to deal with, that the patient's hypoglycemic, typically defined as less than 60 milligrams per deciliter. There's a lot of orders that treat at less than 70. There are some orders that don't treat until it's less than 50. What I've seen most commonly is less than 60 without, or I'm sorry, less than 50 without signs and symptoms, less than 60 with signs and symptoms. But again, whatever your orders say, you're going to treat them. And again, I've seen a lot of orders less than 70 milligrams per deciliter. And then on the other end of the spectrum is going to be your hyperglycemia, your hyperglycemic conditions, your two emergency conditions. And that's going to be when the blood glucose level is extremely high. And that's going to be your diabetic ketoacidosis and your hyperosmolar hyperglycemic non-ketotic syndrome. This most often right now is referred to as hyperosmolar hyperglycemic syndrome. Is they got rid of the non-ketotic because there are some ketones that are being produced. It's not just as much as in the DKA. So you might see this as HHS, HHNS, used to be called HHNC. There's a lot of it, but again, HHS or HHNS is still the most common terminology you're going to find out there. All right, so this is extremely important. Glucose disturbances. Well, we know a couple things. The brain's, and I want to say, you know, it's never, ever, never, you know, but for the most part, the brain really doesn't use anything but glucose as an energy source. There are other, you know, energy substrates, Larry could probably do an hour lecture on, after medical school on all these other little substrates. But the main source of energy, the overwhelming source of energy for the brain is glucose. If the brain doesn't get glucose, it's not going to function. Okay. Now, one thing we know, the central nervous system, when we talk about central nervous system, we're talking brain and spinal cord. Okay. So hypoglycemia not only affects the brain, it affects the spinal cord too. If you remember in the spinal cord injury lecture, don't let your patient become hypoglycemic if they have a spinal cord injury, because it's going to damage the cord just like it's going to damage the brain. So when we say CNS, CNS is referring to central nervous system, and that specifically is referring to the brain and the spinal cord. So what do we know about the brain and the spinal cord? The brain and spinal cord can't make glucose. It can't store glucose. It stores it for a very short period of time. Glucose is stored for about 1 minute and then it's gone. Okay. And it can't concentrate glucose. That means it can't kind of gather it out of the blood. It can't do any of those things. So the bottom line is the brain needs a constant supply of glucose. Brain needs a constant supply of glucose in order for it to function appropriately. So what's the consequence? If there's a brief drop in the blood glucose level, there's profound brain dysfunction. Why? Because if the brain's not getting glucose, the brain's not going to function. And that's why in a hypoglycemic patient, you're seeing this patient's mental status become altered in a matter of minutes. We all know this. The onset in the hypoglycemic patient of an altered mental status is minutes, okay? We know in the diabetic ketoacidosis patient, it could be days, it could be 2 days, 3 days before they start suffering some type of altered mental status. But we know in the hypoglycemic patient, as soon as that blood glucose level drops, it's not enough to feed the brain dysfunctions. What do we see clinically? An altered mental status, irritable behavior, bizarre behavior, patient can't tell you their name, patient doesn't know where they're at, whatever it would be, confusion all the way to coma, and in the worst scenario, seizures. All those seizures only occur in a very small percentage of times, in single digits. Okay, I think it's like 5% or something like that. If you have a prolonged and severe drop in the blood glucose, well, then you're going to end up with cell death. And how cell death occur? You guys remember this? Well, I'm sure you do. Remember I said, you thought, well, I'm never going to use this. Why is this so important and so forth? Well, keep in mind that what's running this machinery is glucose, right? Because if we don't have glucose, we are producing no ATP. And if we have no ATP, we have no energy for the cell to function. And if the cell can't function, the cell can't work. And if it's not working, we're going to see clinically disturbances in mental status, because that's what the brain's going to do. It's going to allow us to move. It's going to allow us to sense things. It's going to allow us to have a conversation, to tell us your name, whatever it would be. So if you don't have glucose and you don't produce the ATP, then what happens? The cell doesn't work. The brain cells don't work. Well, brain cells aren't working. Well, whatever you're seeing. What's your name? They can't even open their eyes. That's an indication that they don't have enough energy because they don't have enough glucose getting into the cell. What happens when no glucose is getting into the cell? Remember the sodium potassium pump? How does the patient's brain die? You guys all learned this. Oh my gosh, do not allow your patient to be hypoglycemic for any period of time, because they can suffer brain cell death. How does the brain die? This is exactly how the brain dies. If we don't put glucose into the brain cell, what happens? The ATP, or the sodium potassium pump, shuts down because there's no ATP to run it. Remember, the sodium potassium pump relies on energy to run it. So it's an active process, okay? It's active transport. We have to actually pump the sodium out of the cell and allow the potassium to enter the cell. And if the pump shuts down, the sodium keeps coming into the cell, and where sodium goes, water follows it. Yeah, I can't remember, Larry. I think it was for every sodium molecule, I believe Larry said it was 3 molecules of water that followed it in. I believe that's correct. But regardless, you're going to get water following the sodium. What happens? The entire time this patient's brain doesn't have glucose, not only are we seeing dysfunction, which again could be what? anything from confusion, bizarre behavior to complete coma. If you got a patient in complete coma, you know one thing, their brain is starving for glucose. It is lacking glucose, severe lack of glucose, because they're comatose. That means their brain, that brain is severely dysfunctioning. And what do we know? That cell continues to swell and swell and swell without the glucose, because we don't have the ATP, and swell and swell. Now, if we get glucose on board, what happens? ATP production starts back up again. And what is sodium potassium pump? Starts pumping sodium out, and the cell begins to shrink and shrink and shrink and shrink. But if we don't get the glucose on board and the sodium potassium pump is not working effectively, cell's going to swell, 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 and eventually the cell membrane ruptures. Once that cell membrane ruptures, that brain cell is dead. How does a hypoglycemic patient's brain die? From a lack of ATP, and is shut down to the sodium potassium pump, causing the cells to swell and eventually rupture. So does a hypoglycemic patient, in a sense, suffer from a cytotoxic edema? You better believe they do. The cytotoxic edema, cellular edema, but you better believe they do, because their cells are actually swelling and swelling and swelling. And if we can catch it, get the glucose on board, get that glucose back in that brain cell, turn on the sodium potassium pump, we're going to wash out the sodium. That cell is going to go back to normal function again. Okay? All right, that's how the brain cell dies. All right, a couple things about glucose that we know. One, glucose is a large molecule, okay? Glucose is a large molecule, all right? Trying to remember why I have blood, urine, and brain. Well, it's going to affect all of those, the blood, the urine, and the brain. Okay. And, it's funny. I'm like, okay. Well, here's the point I want to make, though. Glucose is a large molecule, okay? So it means, what do we know about osmosis and diffusion and so forth? Well, primarily osmosis. There are two things that are going to attract water. Charged particles, well, like sodium and so forth. It's a charged particle, means it's a positive or negatively charged ion. That's going to attract water. Okay, electrolytes. Electrolytes are going to attract water. And the other is a large molecule. Okay, so it's charged molecules and large molecules that are going to attract water. Well, glucose is a large molecule. So that means wherever the glucose moves to, it's going to attract water. Okay, so if there's a lot of glucose in the blood, well, it'll attract water into the blood, or it'll keep the water in the blood. Not too much of an issue at all. Really, it's not. But if there's a lot of glucose that's in the urine, and this glucose is spilling out in the urine, and it's in the collecting ducts and the loop of Henle, it can't get reabsorbed because there's so much of it, that a large amount of it is staying in the collecting ducts and the loop of Henle. What's that large particle doing? It's drawing the water. The water should be all being reabsorbed back into the body, but this big glucose molecule has this osmotic pull, and it's not allowing the water to go back in. So what happens is when you urinate out the glucose, you're also urinating out the water with it. So I know that, we were talking about, I think it was on this one of the lectures. I don't know, it may have been Matt that may have mentioned it. I don't remember, about the brain and glucose. And, back in the early 80s, this is funny because today, if you had a brain injured patient, if you had a patient that was in a car crash, and you said, oh my God, this patient's brain is herniating, and you gave this patient 25 grams of 50% dextrose and brought him in, Matt would probably have you on the carpet first thing tomorrow morning in the inquiry, getting ready to pull your orders. Well, the funny thing is, as Matt always clearly points out, is, a lot of things we taught Matt, and, they're wrong today. And that's the beauty of EMS, because we rely on evidence-based medicine. When I was working as a paramedic in the early 80s, believe it or not, we gave 50% glucose. We gave the patient 25 grams to 50 grams of glucose if we suspected they had a brain injury. If they had a stroke, they got glucose. If they had a head injury, they got glucose. And the theory behind it was, and this was the theory because they were giving it in the emergency department too, was if you loaded up the blood with glucose, it's going to have an osmotic effect. And what it's going to do is it's going to take that edematous brain tissue and it's going to suck that edematous brain tissue water, all that extra fluid in the brain, it's going to suck it back into the vascular space. And then we turned around and we would give Lasix for them to pee it off. Well, I mean, the theory at the time made some sense because you said, well, glucose is a big molecule and it's going to attract water. So as it's circulating through the cerebral vessels, it's pulling all that edema, water and the edema back into the vascular space. And look, you're decreasing intracranial pressure. Well, what we found, later on, and again, this wasn't an EMS thing. This was the thing that was being done in trauma and in the emergency departments. We found that we were actually, for the most part, killing patients at the, stroke patients, brain injured patients, and so forth. And why is that? Well, we know one thing. We know the brain doesn't need insulin to get a glucose molecule across. Okay, so the brain doesn't need any insulin to get a glucose molecule across. So that means that glucose will freely cross the blood-brain barrier, unimpeded. If it's in the blood, it's going to cross over. So now think about it. Instead of us actually drawing water into the vascular space, when all that mass amount of glucose hit the brain tissue, it traveled over into the brain cells, and what did it take with it? All this water. It actually made the brain injury worse. But again, at the time, it was based on theory, and they were finding the neurologic outcomes in patients were much worse when they were given glucose, so it was all stopped. But that was the theory behind it. And the point I'm trying to make is the reason why it was done is because glucose is a big molecule and it's going to attract water. So, but the point that I also want to make is this is why you never, ever, ever want to give a stroke patient, a head injured patient, or any patient with any type of intracranial pathology with an increase in intracranial pressure glucose if they don't need it. Okay, if they don't need it. Now, in a stroke patient, you kind of ride a fine line, and you have to check the blood glucose level. You have to check the blood glucose level in a stroke patient, in a head injured patient, in a spinal cord injured patient, because if they're hypoglycemic, you are going to worsen their neurologic outcome if you don't give them glucose. But if their blood glucose level is normal and you give them glucose, you are going to worsen their neurologic outcome. So this has to be guided by pretty precise blood glucose monitoring. And we know those capillary glucose monitors aren't all that great. And I think Larry or Matt mentioned that there are venous monitors out there, but they cost more money. Venous blood is a lot more. The golden standard actually is a blood serum sample. It's the serum sample. And not a capillary or venous sample. But anyways, so in the stroke patient, head injured patient, if they need glucose, you better give it to them. Because if you don't give it to them, they're hypoglycemic, you're going to worsen neurologic outcome. But if you have a stroke or head injured patient and you give them glucose, well, and they don't need it, all that glucose is just going to flood the brain cells, take water with it, and you're going to worsen the cerebral edema. So hopefully that makes sense. Okay. All right, what do we know about insulin? Insulin increases glucose transport by 10 times in cells, in peripheral cells, okay? But we know one thing, the blood-brain barrier does not need insulin. This is a key to a lot of these conditions. The blood-brain barrier does not need insulin. All right, so what's the function of insulin? We know one thing. When insulin gets secreted, insulin is secreted by the pancreas, the islets and Langerhans. It's secreted by the beta cells. And when insulin is secreted, its major function or its major after effect is the blood glucose level goes down. Put insulin in the blood glucose level goes down. Why does it go down? Because one, it facilitates the movement of glucose into the liver. About, again, 2/3 of it goes into the liver in the form of glycogen, the stored form of glucose. And the reason for that is because it gets you through to your next meal, where that glucose is being put back into the blood to get you through to your next meal. And the other thing that it does is it allows glucose to enter the cells. Insulin doesn't carry glucose into the cell. Insulin, as you can see in this graph right here, insulin triggers a receptor site on the cell membrane, an insulin receptor site. And when it triggers a receptor site, it opens up a glucose channel, and the glucose molecule is actually carried in by facilitated diffusion by a protein carrier, okay? So insulin doesn't carry glucose into the cell, but insulin is necessary to hit the receptor site, trigger the receptor site, glucose channel opens, and the glucose is carried in by a protein. So when insulin is in the blood, what you're doing is you're allowing glucose to enter into the cell, okay? If you don't have insulin, there's nothing hitting that receptor site, nothing. The glucose just keeps going by because those channels aren't open, okay? Put insulin in the blood glucose level goes down. If the blood glucose level is high, then what happens is insulin gets secreted. The insulin level is going to go up. If the blood glucose level is low, the insulin level is going to go down. This is not abnormal. This is the normal thing that's occurring in the body. And I have a graph I'll show you that'll make more sense. If there's too much insulin in the blood, the I represents insulin, the G represents glucose. If there's too much insulin in the blood, what happens is all these receptor sites on the cell are getting insulin, boom, 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 boom. And all these glucose channels are open up on the cell. And what's happening? Glucose is bombarding the cell now because there's so much insulin. And so what's happening is all this glucose is going into the cells, going into the cells, going into the cells. Okay, because insulin is basically sending it there. What doesn't need insulin? The brain. Look what happens. What's left over when that blood gets to the brain? A lot of insulin, very little glucose. So if there's too much insulin in the blood, the insulin is putting all that glucose into the cells, but it's not leaving enough left over for the brain because the brain doesn't need the insulin. It doesn't have the insulin receptor sites. This is where it's all going into the cell. Okay. So too much insulin in the blood, the peripheral cells, they're happy as hell. The brain is getting very little glucose. Brain cells are not very happy at this point. They're not happy because the brain is starving. And when you don't put the glucose into the brain cells, you start noticing the clinical dysfunction that we're going to find in the hypoglycemic patient. All right, so glucagon. I said earlier, glucagon is a hormone. You may carry glucagon on the ambulance, okay? And we said glucagon's a hormone. Glucagon comes from the islets of Langerhans. It's secreted by the alpha cells. And its major functions, again, is glycogenolysis and gluconeogenesis. It takes that glycogen in the liver, the stored form of glucose in the liver, splits it back apart and sends it back out in the blood as glucose. Then it takes non-carbohydrates in the form of primarily fats and proteins, sends them to the liver to produce glucose substances, and sends them back out into the blood to do what? Raise the blood glucose level. So when you put when glucagon is secreted, it raises the blood glucose level. Remember, when insulin is secreted, it lowers the blood glucose level. When glucagon is secreted, it raises the blood glucose level. So if the blood glucose level is high because you just ate a carbohydrate meal an hour ago, the glucagon level is going to be low. But as the blood glucose level begins to fall because it's now 4 hours since you ate, the glucagon level is going to go up to do what? Take that stored form of glycogen, stored form of glucose in the form of glycogen, split it apart, and put it back in the blood until you do what? Eat again. Okay? Now, this is actually important, okay? Now, it's kind of interesting now, that now they're saying even the fasting blood glucose, a 12-hour fast for blood glucose should be 80 milligrams per deciliter. But still, if you got somebody, as far as we're concerned, who has fasted, for 8 to 12 hours, their blood glucose should still be about 80 to 100 milligrams per deciliter. And how do you know that? Now, here's the thing, too. Don't ask your patient when you're going to test their blood glucose, when was your last meal? Especially the elderly. The elderly will say, well, my last meal was 5 o'clock last night. and this is 10 o'clock the next morning, because that was their last meal. But they'll fail to tell you that they had ice cream, they had 2 Twinkies, they had a Snickers bar, they had a Pop-Tart this morning. Those aren't meals, those are snacks, okay? So what you want to really ask your patient when was the last time you had anything to eat or drink? Because when's the last time you had something to eat? They'll tell you, I haven't eaten since 5 o'clock last night and it's 10 in the morning. Yeah, but they just had, 2 Coca-Colas and, and a Powerade, loaded with glucose, loaded with carbohydrate. So make sure you ask them, when was the last time you had anything to eat or drink? If it's been 8 to 12 hours in the non-diabetic patient, their blood glucose should be about 80 to 100 milligrams per deciliter. 1 hour after a meal in the non-diabetic patient, non-diabetes mellitus patient, expect their blood glucose to be 120 to 140. Don't be alarmed. Don't take their blood glucose because they just ate an hour ago, and they ate breakfast. They went to Bob Evans. They got the super pancake meal with syrup and everything. And then you test your blood glucose, an hour and a half later, and you're like, holy shit, it's 140. I think you're a diabetic. No, that's what's expected, okay? So about an hour after a meal, that includes carbohydrates, typically a normal meal, a sandwich, whatever it would be, the blood glucose in a non-diabetic patient goes up to about 120 to 140, okay? Keep one thing in mind, capillary blood is 10 to 15% higher than venous blood. I believe it was Matt that told you guys, do not take the back of the angiocath off the collection chamber, blood collection chamber, and drop that on your glucose stick, because that's venous blood, because venous blood has a tendency to be 10 to 15% lower than capillary blood. That means you're going to get an erroneous reading of 10 to 15%, okay? So that means, think about it. If this patient is on this, fine line, okay, and it's a stroke patient, all right, and their blood glucose is really 72, but you take venous blood and you drop it on your capillary glucometer and it's 10% lower, that means that's going to be 7.2. They're going to read in the 60s. And what are you going to do? Give a stroke patient glucose that doesn't need glucose. If it's a capillary glucometer, use capillary blood. If it's a venous glucometer, use venous blood. Do not trade off. People say, I actually did a short research project on this and want to know, why are people violating this? And most people said, well, I don't want to stick them a second time. Well, it's more laziness than anything. And they're like, well, I don't want to stick the patient. Really? You have no problem sticking them with a 14-gauge needle, but you're afraid to stick them with a little lancet. I think a lot of it was just, well, it's convenient, so let me just drop it. Don't do it. Stick them, do a finger stick, do a capillary stick, heel stick, wherever you need to do it. Get capillary blood. All right, so this is in your non-diabetic patient. This is how normal metabolism works. This is very elementary, but it'll make sense. So you eat a meal. You look at the top. You look at the top here, you eat a meal. Your blood glucose level goes up to 120, 140. Again, this is in a normal person without any diabetes mellitus. Blood glucose goes to 120 to 140. What happens? Insulin now is secreted by the pancreas because the blood glucose level went up. Insulin is secreted. What's insulin's job? Bring the blood glucose level back down. How does it do it? It starts triggering insulin receptor sites on cells, starts opening glucose channels, and allows the glucose to get into the peripheral cells. And what does it do? It's promoting the liver to take up the glucose, and it starts forming the stored form of glucose, glycogen. And the muscle is creating stored glycogen also. So what happens now? You don't eat for several hours, and your blood glucose level drops to 70 milligrams per deciliter because now you haven't eaten for several hours. Well, because your blood glucose level is down, the insulin secretion shuts off, and what happens? Glucagon is then secreted by the pancreas. And what does the glucagon do? It now starts doing what? Taking that glycogen, splitting it apart, and sending that glucose back out in the blood. And on a severe end, it may take, amino acids or fat and convert it. But for the most part, in this case, it's just taking that stored form of glycogen, it's converting it back, it's splitting it apart, it's putting it back in the blood. So you maintain a blood glucose level at about 70 or 80 or 90 or whatever it would be until you do what? eat your next meal. And this whole process starts over again and over again and over again. Okay. That's normal metabolism for a normal person. Okay. Blood glucose level goes up, insulin gets secreted, drops the blood glucose level. It then falls down to a point where it's at a threshold where you need glucose in the blood. Insulin shuts off, glucagon turns on, starts taking glycogen, converting it back into glucose, may take some fat, may take some proteins, and you maintain that blood glucose level until you eat another meal. If you didn't have this, you would crash several hours after you ate. And you would crash, and then somebody have to give you some, D50 or, 10, D10 or whatever it would be, So now this is your type 1 diabetic patient. This is your type 1. Type 1s used to be known as IDDMs, insulin-dependent diabetes mellitus, because their pancreas, for the most part, their beta cells are not secreting insulin. So what happens to the diabetic patient who is dependent on insulin? They eat a meal, their blood glucose level goes 120 to 140. They don't have insulin in their body, so there's no insulin that's secreted. And their cells are not uptaking glucose because there's no insulin to do what? Trigger the receptor site to open the glucose channel, so the glucose is staying in the blood. Now, the liver will still take on glycogen, okay? It'll still take on glycogen, but this glucose is not getting into the muscle. This glucose isn't getting into the peripheral cells and so forth, but it's staying in the blood. But what do we know about the brain? Brain doesn't need insulin. Brain's thrilled, brain's happy, brain's getting all this glucose. Is this patient going to be alert, awake? This person can tell you everything. They'll tell you everything you want because their brain is getting all the glucose, because all the glucose is staying where? In the blood. So does the blood glucose level drop? No. It stays at 120 to 140. Well, it may drop a little bit because the brain's using the glucose, but it stays up. It stays elevated. Okay? But the cells are not getting any glucose. So what happens next? They eat again, and the blood glucose level goes up even farther. It goes up to 280 milligrams. I made these numbers up. It's just arbitrary numbers. That goes up to 280 milligrams per deciliter. But the patient, because they're type 1 diabetic, they don't have insulin, and they're not taking their insulin. So what happens? The cells still have no insulin to allow the glucose to get into the cell. And the cells are like, what the hell? We're not getting any glucose. Hey, we're really hungry here. We need glucose. And the glucose level stays at 280 because there's no insulin to lower it. But the peripheral cells now are telling the hypothalamus, hey, we're hungry. Well, what do we know about the brain? Brain's happy as hell because the brain doesn't need insulin. The brain's getting all this glucose. It's like a wine grape festival with cheese. It's like, this is awesome. I got all this glucose. This is wonderful. Well, what happens? The patient eats another meal. Now the blood glucose level goes up to 400. They still don't have any insulin. Cells still aren't getting any glucose. All the glucose is going past the cells. Insulin receptor site's sitting there, but there's no insulin to trigger it. The glucose channels are closed. There's no insulin. So the blood glucose level stays up to 400. But what happens now? The cells are telling, not the brain cells, the peripheral cells are bombarding the hypothalamus saying, we're starving, we're starving, we're starving, we're starving, do something. So what does the hypothalamus do? Because now the cells are in a starvation mode, the hypothalamus tells the pancreas to secrete glucagon. What does the glucagon do? Starts converting all the glycogen that was in the liver into glucose and starts converting fat, some amino acids and fat, into glucose. What happens to the patient's blood glucose level? It goes up even higher. And the cells are continuing to starve because there's still no insulin to get the glucose into the cell. But the brain at 600 milligrams per deciliter, loving it, loving it, loving it. Got more glucose than it knows what to do with. It's like, it is freaking out. It's like, this is awesome. Best day ever. 600 milligrams of glucose as the peripheral cells are starving. And this continues. And you can see that what starts out being kind of like this negative feedback mechanism to protect you ends up actually raising your blood glucose level and making you worse. Is this patient going to be have an altered mental status? Hell no, they're not going to have an altered mental status right now because their brain has so much glucose, doesn't know what to do with. Okay. But what's happening? Their peripheral cells are starving. And so we start pumping out a lot of substances. We start burning a lot of fat now through gluconeogenesis. Fat, because once the liver is done, the liver can only send back so much glucose. Once the glycogen stores are done, they're done. And it's pumping out now. It's burning fat. And then the liver, in an attempt to make glucose, what's it producing? Ketones. Okay. That's your diabetic patient. That's how they get into a hyperglycemic event right there. Okay. Hopefully that makes sense. So if you have low to no insulin, it leads to too much glucose in the blood. If you don't have insulin, the glucose is going to stay in the blood because you don't have the insulin to put it into the cells. So we know about the brain cell here on the left, happy as hell. Brain cells like, oh, this is like a pig in mud. This is awesome. The peripheral cells, they're starving. They go into a starvation mode and they trigger the brain. They trigger the hypothalamus now to get us out of the starvation mode. And what does the brain do? It wants to burn other stuff to try to make more glucose. We got to make more glucose. Why does the body want to make more glucose? Because the cells aren't getting glucose. We got to make more glucose. Although the brain and the blood's like Cairo syrup. But the body thinks we got to make more glucose to get it to the peripheral cells, where realistically it just needs the insulin. Okay. Now, in the diabetic patient, a random blood glucose in a diabetic patient, randomly tested blood glucose in a diabetic patient, it's typically around 200 milligrams per deciliter. That means if you randomly tested a blood glucose level in the diabetes mellitus patient, it is around 200. But a fasting blood glucose level is typically greater than 140. So now if you have a patient who truly fasted for 12 hours, 8 to 12 hours, truly fasted, had no carbohydrates, drank nothing but water, and their blood glucose level is 140 or higher, now you're dealing likely with the patient who has diabetes mellitus and they're hyperglycemic. And again, in a lot of cases, you're the first one to find this. Okay. So now remember, in the patient without diabetes mellitus, about 1 hour after you're eating a meal, 2 hours after eating a meal, their blood glucose level normally is going to be 120 to 140. This is a patient now that has been fasting for 8 to 12 hours, has had nothing to eat, if anything, drank some water, and they have a blood glucose of 140 or higher. It's a good chance this is going to be a diabetic patient. This patient has diabetes mellitus. Now, there's counter-regulatory hormones, okay, that are designed to increase the blood glucose level in addition to glucagon. Okay, so there are other hormones in the body that actually will assist with raising the blood glucose level. Now, we know there's one hormone that's going to decrease the blood glucose level, and that's insulin. That's it. But there's several hormones that will get secreted to try to raise it. So when those cells are in that starvation mode and so forth, you could get glucagon being secreted and so forth. But the other thing is, if the patient is hypoglycemic, when the patient becomes hypoglycemic, these hormones are going to get released. If the blood glucose level is too low and the brain now is not getting an adequate amount of glucose, it becomes irritable. It's not getting the glucose because you don't have it in the blood. You have hypoglycemia, low blood glucose level. All of a sudden, now these hormones get secreted. Glucagon, we know what glucagon is going to do. It's going to start taking the glycogen in the liver and start converting it back and sending it back as blood or as glucose in the blood. And then it's going to take non-carbohydrates through gluconeogenesis, and it's going to try to convert them and put them back in the blood. But what do we know? We said a brief drop in the blood glucose level is going to cause severe neurologic dysfunction. Okay, so we're talking about minutes. Okay, but here's one thing we know. Well, the glucagon is going to kick in, but here's another look. Counter-regulatory hormone is epinephrine. That means epinephrine will get secreted when the blood glucose level is low. Okay, epinephrine will get secreted when the blood glucose level is low. These are counter-regulatory hormones that are attempting to raise the blood glucose level. They're not being secreted when the blood glucose level is high. They're attempting to raise it. So glucagon will try to raise the blood glucose level. Epinephrine has an effect that it actually will cause glycogenolysis and gluconeogenesis, similar to glucagon. But we know the other effect is what? Alpha and beta. And those are out there. Epinephrine gets secreted. You're still getting the alpha 1, alpha 2, beta 1, beta 2 effects. But you're also getting a glycogenolysis and a gluconeogenesis effect too. Growth hormones takes a long time. Cortisol, it's over time. Norepinephrine is going to act like epinephrine somewhat too, where it's actually going to stimulate gluconeogenesis, glycogenolysis, but nowhere near epinephrine. So the two primary hormones, when the blood glucose level is low, brain's not getting enough glucose, it starts hammering out glucagon and epinephrine. Keep that in mind. Keep that in mind. We already said when the blood glucose level is less than 70 milligrams per deciliter, that's when epinephrine starts kicking in. When your BGL gets less than 70. Let me ask you guys this. If you're ever working on the ambulance, this used to happen. We worked 24-hour shifts. We started at 7 a.m. We'd go in at 7 a.m. and we would start running, in Youngstown. Back in the day in Youngstown, in the early 80s, we were running 16 to 18 trips in a 24-hour period. I mean, we were we were running, and it was busy. And there were days that we would start at 7 in the morning, and we were eating our first meal at 7, 8, 9 o'clock at night. So let me ask you this. Have you ever had those days where you don't eat a meal and you're going for hours? You're going for hours now. It's been like 8 hours, 10 hours, 12 hours, beyond the 8 or 10 hours that you didn't eat overnight, and you didn't eat a meal. And now it's like, Jesus, I ate 5 o'clock last night. Now it's 5 o'clock the next day. It's 24 hours since I had anything to eat. What do you notice? Do you notice you start shaking? Your heart rate's elevated. You start to sweat. You start looking like pale and pasty. You get real irritable. You get angry, hangry. Okay? Why is that? Well, what's being secreted now, because your blood glucose level is at the critical level and it's probably dipping below 70. Epinephrine now is being secreted. What's alpha 1 doing? Causing vasoconstriction, causing you to look what? Pale, because you're taking all that nice warm blood, shunning it away from the periphery, putting it in the core of the body. What else does alpha 1 do? Stimulates the sweat glands. You ever notice you sweat? You ever have a diabetic patient who's hypoglycemic? A hypoglycemic patient. You ever get a hypoglycemic patient and they are drenched in sweat? They're drenched. They are diaphoretic. They are drenched. That's because alpha 1 in the epinephrine stimulates the sweat glands. Why are they so drenched in your why is the hypoglycemic patient so drenched, but the hypovolemic patient isn't? When epinephrine is being dumped out in the hypovolemic patient, well, the hypovolemic patient doesn't have the volume to sweat. The hypoglycemic patient has a complete normal blood volume, so therefore they are dripping in sweat. So you get the pale skin, you get the clammy skin, but really you're getting the severe diaphoresis. Beta 1 does what? Increases the heart rate, right? Inotropic, dromotropic, chronotropic. This patient will say they feel their heart like it's beating in their chest, but they're going to be tachycardic, right? And the tremors that you see, that's from the beta 2 actually affecting the skeletal muscle, stimulating skeletal muscle. So you're going to get the tremors, the pale skin, the cool skin, the diaphoresis, and the tachycardia. In some cases, their blood pressure may actually increase. And what does the epinephrine do? Well, the reason why it's secreted is nothing for those effects. Those are side effects, but those are good clinical indicators the patient is hypoglycemic. What does it do? Epinephrine will shut down insulin secretion, and it will do glycogenolysis and gluconeogenesis in an attempt to raise the blood glucose level. Okay? So epinephrine is coming out with glucagon once that blood glucose level gets less than 70. Okay? So here's one thing I want you to know. If you want to know the signs and symptoms of hypoglycemia, there's only two things you have to remember. One, Hypoglycemia, low glucose in the blood. And we have a low glucose level in the blood. That means the brain doesn't get an adequate amount of glucose. Okay. And when we don't put an adequate amount of glucose into the brain, we can't make the ATP to allow the brain to function normally. And if the brain doesn't function normally, it dysfunctions. And so what happens? What do we see clinically? Altered mental status. Anything from confusion to complete coma to seizures. That's called a neuroglycopenic or a neuroglucopenic effect. Penic means lack of glucose in the brain, neuroglucopenic. So what's one whole group of signs and symptoms you're looking for? Not enough glucose in the brain. I see an altered mental status. That could be anything on this continuum. The more severe the altered mental status, it's likely the more severe the lack of glucose in the brain. What's the second set of signs and symptoms? They're called hyperadrenergic. Adrenergic is referring to the adrenergic nerve fibers that are sympathetic, and they cause epinephrine sympathetic-like effects. And this is from the epinephrine. So here's the thing: you look, if you want to know how many, it's funny. I wish I could see. I wish this was in person, but how many of you remember? This is another going to tell you the old time experienced people. How many of you remember when they used to call this insulin shock? And the reason why they called it insulin shock is because the patient looks like they're in hypovolemic shock. Why do they look like they're in hypovolemic shock? Because they got a shitload of epinephrine that's being dumped out in the body, just like the hypovolemic shock patient. They're pale, they're cool, they're diaphoretic, they're tachycardic, okay? They got tremors. That's all from the epinephrine. So if you want to know the signs and symptoms of hypoglycemia, brain cell dysfunction from not enough glucose in the brain, epinephrine. And you should already know what the epinephrine signs and symptoms of epinephrine circulating, adrenaline. That's it. Those are all the signs and symptoms of hypoglycemia. You got to memorize some list. You don't got to memorize any of that stuff. This is what it is right there. All right. Anxiety, tremors, diaphoresis, pale, cool, clammy skin. Anxiety is another too. That's a good one. All right. So pathophysiology and diabetes mellitus. So in the diabetic patient, the blood glucose level is commonly 300 to 500 milligrams per deciliter. That's pretty high. Again, we're saying a normal fasting blood glucose is, well, now they're saying a fasting blood glucose should be 80 milligrams per deciliter. That's just recently they changed that. And after a meal in the non-diabetic, again, 120 to 140, somewhere around there. Okay, so, but in the diabetes mellitus patient, they're commonly struggling with blood glucoses of 300 to 500. Remember I said, every day, diabetes mellitus patients struggle to bring their blood glucose levels down. Not up, down. They're hyperglycemic chronically. They are chronically hyperglycemic. Why? Because they don't have insulin. If you don't have insulin, the blood or the glucose just hangs out in the blood. The brain's thrilled, cells are starving. But here's another problem. Once the blood glucose level hits 180 milligrams per deciliter, you start spilling the glucose into the urine, okay? Once it hits 225 milligrams per deciliter, a significant amount of glucose starts spilling into the urine. When I say spilling into the urine, I mean that glucose is now being urinated out. That glucose molecule, there's so much glucose in the blood, this glucose can't be reabsorbed in the loop of Henle or the distal tubules, and that glucose now is being retained, and because it's a large molecule, it's sucking all this water with it. Remember we said one sign of diabetes mellitus is polyuria, and that's why you're getting the polyuria, because all that glucose is staying in the collecting duct, drawing the water, and then the person's just urinating off. And what's this going to cause? If you're urinating water all the time, you become dehydrated. And when you become dehydrated, your hypothalamus, your thirst center, tells you what? Drink, causes you to be thirsty. And that's an imbalance between the solute and the solvents, okay, the water and the particles. There's an imbalance, and you become thirsty. So what do? Because you're urinating all the time, you're drinking all the time, you just urinate off whatever you're drinking. And the urine has the tendency to be very clear because you're urinating off so much fluid with it, okay? And this is just an example here where the glucose is being reabsorbed, 100% reabsorption of glucose. Here in the diabetic patient, there's so much glucose, it can't get reabsorbed, so you're spilling off glucose into the urine. All right, so what's another problem that happens in the diabetes mellitus patient? We already said this, because the blood glucose level stays high and there's no insulin to allow the glucose to get into the cell, not the brain cell. Brain doesn't need insulin. It's getting tons of glucose, but the regular cells, they now start to starve. And because they're starving, glucagon gets released, and the glucagon is dumping back the glycogen. That's only going to last for so long. And once that's gone, then it starts doing what? Primarily taking fat, and it starts to metabolize fat. And it's metabolizing the fat in the liver, and it's trying to convert the fat to form a glucose substance that can be used by these starving cells. But it doesn't matter. Why? Because if there's no insulin, it doesn't matter how much glucose you put in the blood, it's still not going to get into the cell because you don't have the insulin to trigger the receptor site to open it up. But the problem with this is it starts burning fat. And the hypothalamus says, but we need more glucose. So it says burn more fat. And we need more glucose because the cells are still starving. So we burn more glucose or more fat to produce more glucose. And the glucose level is going up and the cells continue to starve. But the problem with this is when you catabolize fat in the liver, you produce ketones. And ketones are a group of strong organic acids: acetoacetic acid, beta-hydroxybutyric acid. Oh gosh, Larry, help me. Or Matt. Acetoacetic acid, beta-hydroxybutyric acid. Shit. What's the third one? Acetoacetic acid, beta-hydroxybutyric acid. Dave, Yash, help me. Somebody help me. There's a third one. Nobody? Everybody sleeping out there? You like heal? Okay. Beta-hydroxybutyric, acetoacetic acid. The third one's the most common one. I can't think of it. Regardless, anyway, so what happens, you start producing these massive amounts of ketones, which are these
Acetone.
acetone. Oh my God, thank you. It's the most common one. Thank you. Who was that? Was that Tom Young?
Well,
Will Ferrando.
yeah.
Son of a bitch. Wow. Will, I'm going to give you extra credit. Jeez. Acetone. Thank you, Will.
10 years too late.
acetone. So those are your three organic acids. And acetone is real important because of the signs and symptoms. But those ketones are strong organic acids. And really the only way to get rid of them is you have to urinate them off. You can't get rid of them any other way. You got to urinate them off. But in order to urinate them, because they're such strong acids, you got to buffer them with sodium. So what does that mean? So now you're taking and you're attaching a sodium to these acids to urinate them, so you're buffering them so they're not so strong acid, and you're excreting sodium now. And where sodium goes, water follows it. And as you're excreting sodium, you're retaining hydrogen. And hydrogen is what? An acid. Okay? So it's like, this is all like working against the body. All right. Yeah, well, it's just an illustration there that one thing here, this makes sense here. Amino acids are producing hyperglycemia with severe osmotic diuresis. This becomes important when I explain HHNS versus the DKA. The DKA is burning this adipose tissue, man. They're burning adipose tissue, and they're trying to make, glucose, and they're producing massive amounts of ketones, and they're, hyperketonemia and so forth. But in HHS, they're producing, or they're burning primarily proteins. So they're not producing massive amounts of ketones. We'll talk about that. All right, so in hyperglycemia, when the blood glucose level is extremely high, what are the brain cells? Happy as hell. What are the peripheral cells? Starving. Because all the glucose is where? In the blood. We don't have the insulin to open the glucose channel to allow it into the cell, and the peripheral cells are starving. We get polyuria, we get polydipsia, we get polyphagia. Let me ask you this. Why do you have polyphagia? Polyuria, we know, because the glucose is being spilled out in the urine. It's a big molecule, and with that big molecule is going water. And the polydipsia is because you're urinating so much, you're becoming dehydrated. Hypothalamus, thirst center says, hey, this ratio's off. You're thirsty. You better drink. We got too many solutes, not enough solvent. But why the polyphagia? Why are you hungry all the time? Why are you hungry? Your blood glucose level is 600 and you're hungry. Why are you hungry? Because your peripheral cells don't have glucose, because there isn't insulin. So the brain is telling your body they're starving. Your cells are starving. They're in a starvation mode. That's why the patient's hungry all the time. Do they need to eat? Hell no. The last thing they need to do is eat because their blood glucose level is so high. All right, the two different types of diabetes mellitus. Type 1, again, used to be known as IDDM, insulin-dependent diabetes mellitus. Type 2 used to be known as non-insulin dependent diabetes mellitus. But the reason why they changed that now is because there are type 2 diabetics that end up becoming insulin dependent because they can't control their glucose with oral hypoglycemics. Type 1s, typically juvenile onset, most common less than 40 years, but again, you could be older. A lot of them have a tendency to be a leaner weight type 1 because they're burning so much fat trying to maintain glucose, to try to get glucose to their cells. They have no insulin levels. Glucagon levels are often high. They have the 3 Ps, because they're hyperglycemic. They're hyperglycemic all the time. Beta cells are destroyed. There's theories behind how they get destroyed, autoimmune disorder. I mean, there's lots of different virus, things like that. DKA is a much more common condition in type 1. That's very important. DKA is more common. And DKA is a common condition in type 1. Hypoglycemia, although it's a rare event for type 1 diabetics, it is much more common to have a type 1 diabetic and hypoglycemia than a type 2. Although hypoglycemia can occur in a type 2 diabetic, keep that in mind. DKA is a much more common condition on type 1 than type 2. Type 2 is HHS. Type 1 is a lot less common than type 2. Type 2 diabetics are everywhere. Type 1 diabetics, it's a lot less common than type 2. Type 2 diabetics, again, it's probably every third patient you pick up is a diabetic. It's type 2. Type 1's not as common. Type 2s, usually middle age or older. They're usually obese. Their insulin levels are low, normal, or high. How could it be that a type 2 diabetic patient could have a high insulin level, but yet have a high blood glucose level? They have a high insulin level and a high blood glucose level. You say, well, that doesn't make sense, because if their insulin level is high, their blood glucose level should be low. Well, in these patients, what typically happens is the insulin receptor site is no longer sensitive, or the insulin itself is no longer real active. And so therefore it's not triggering the insulin receptor site and opening that glucose channel. That's how you could have a high insulin level and a high blood glucose level. Okay. And typically they have a problem with their beta cells secreting insulin, but they're still secreting insulin, some insulin, maybe not enough. Maybe a lot of insulin, it's just not a real active form, or maybe a lot of insulin, a normal amount of insulin, the receptor sites just can't pick it up. They have gradual onset signs and symptoms. These are the people that can control their diabetes through diet, exercise, oral hypoglycemics. In severe cases, they have to go on insulin. These patients will suffer HHNS or HHS a lot more often than DKA. It's rare for these people to go into a DKA. And they could experience a hypoglycemic event, although that's rare. If this person is on, okay, so type 2 diabetics do not take insulin usually. What they take is the pill, and that pill is not insulin. Insulin is injected. They used to have the insulin spray, like the meter dose inhaler, and they found that wasn't real effective. And even the people that did the meter dose inhaler, they still had to inject insulin. Insulin is injected. The pill is an oral hypoglycemic agent. It is not insulin. A person who's a type 2 diabetic who takes an oral hypoglycemic drug like glucophage, diaminase, tolinase, whatever, metformin, whatever they are, those drugs are designed specifically to either increase the amount of insulin being secreted by the pancreas, or they're designed to make the insulin receptor sites more active, or they're designed or more sensitive, or they're designed to make the insulin itself more active, or they're designed to decrease carbohydrate absorption in the gut. And some have more than one function, but they're not insulin. Okay. Now, the people that take the oral hypoglycemic, that has a tendency to cause an increase in the secretion in insulin, are the ones that if they take that oral hypoglycemic and they're not eating over a period of time, these patients could actually suffer a hypoglycemic event because now they have too much insulin and they don't have enough glucose because they're not eating, and they could suffer a hypoglycemic event. Although hypoglycemic events in type 2s is rare. Here's your insulin resistant cells. You know, they just won't pick up the insulin, and so the insulin just keeps going by, and going by with the insulin is the glucose because it won't let it through. Okay, we talked about the diabetic emergencies. Hypoglycemia, what do we know? There's too much insulin, not enough glucose. Why is there too much insulin? It's usually because of a mistake by the person taking the insulin. And this is a lot less common anymore. It's a lot less common with the insulin pumps. The insulin pumps are pretty unique devices, but there are still people out there that inject the insulin because either they can't afford the pump or they're not, able to use the pump for some reason, whatever it be. So there's still people that inject the insulin. This is where a person either takes too much insulin, and it can happen where they take their insulin and then they forget, they eat, and their insulin is based on what they're eating. They eat, and then they go like, I didn't take my insulin today. And they take another dose of insulin. Or they take their insulin, they eat, and they throw up. Or they take their insulin, they go like, oh my God, I can't eat. I'm so nauseous, I'm going to throw up. So there's too much insulin for the blood glucose. So what happens, the blood glucose level drops. When the blood glucose level drops, there's not enough glucose, but there's a ton of insulin. So whatever glucose is left in the blood, where's it going because there's so much insulin? Hitting the insulin receptor sites, sending to the peripheral cells, not enough left over for the brain. Most dangerous acute complication, why? Because this is where the brain can die very quickly. Because if you don't put glucose into the brain cell, it doesn't function. ATP pump shuts down or the sodium potassium pump shuts down because there's no ATP. Cell swells, cell ruptures, patient dies. Okay. It's the most common cause of coma in diabetes mellitus patients, and most often it's due to the excessive administration of insulin. Severe hypoglycemia is considered to be 40 to 50 milligrams per deciliter. Realize one thing, there is no standard. We used to have a woman, her name was Mary. Actually, she's dead, so it's not HIPAA violation, Mary Beniston. And she lived in Boardman, on the north side of Boardman. And we used to go to her house. I know John Booth was almost like a permanent partner of mine. And we used to go to her house at least like once a week. And she was a diabetic, and she was actually bulimic. And so she would eat like a whole box of Hostess cupcakes, take her insulin, eat a whole box of Hostess cupcakes, and then she would vomit it all up. And then she would become hypoglycemic. And I remember she would greet us at the door sometimes with a blood glucose of 25. 25. I mean, so you can't say in one patient, a blood glucose of 50 in one patient, they may be comatose, and a blood glucose of 50 in another patient, and they're sitting there and they're telling you their name and everything else. So you can't say that at a certain point. Everybody's different. The blood glucoses are different, and they respond differently. So you can't put like this number on it, okay? And these are, causes of insulin excess too. And again, the most common cause is they just take too much insulin, okay? And if they take too much insulin, we have too much insulin on board, where's all the glucose? All the glucose is in the peripheral cells now because the insulin's putting it there. And what's not left over, glucose for the brain cells, okay? Peripheral cells are happy, brain cells dying, okay? Signs and symptoms, remember the neuroglycopenic. That's where you don't put glucose into the brain doesn't function. Anything from confusion, again, to seizures and so forth, okay? Hyperadrenergic is from the epinephrine that's being secreted. Okay, that's going to be, again, the tachycardia, the the pale skin, the cool skin, the diaphoresis, severe diaphoresis, the palpitations, dizziness, anxiety, the tremors, and so forth. That's all from the epinephrine secretion. This is a little mnemonic I saw, and I thought, I don't know, it was okay. Tired, tachycardia, irritability, restless, excessive hunger. But hypoglycemics don't have excessive hunger. Excessive hunger you're going to find in the DKA patient. diaphoresis, depression. I don't know. It's not that great. I don't know. I should probably take it out of there. Look, it's a nursing. From nursing, go figure. Anyways, there's a thing called hypoglycemia unawareness, and this is where a patient actually is gets used to. So in hypoglycemia unawareness, and I'm sure you guys have had these patients where you have these diabetic patients that are fairly regular, and they're not like they're abusing EMS, but they're fairly regular because they become hypoglycemic, and maybe the wife calls, the husband calls, the daughter, whoever will call, and they say like, oh, they're becoming hypoglycemic, so we called, and you get there, you give them their glucose and stuff, and they know their signs and symptoms, and they typically know when they're becoming hypoglycemic, and what do? They take care of it themselves. They eat a carbohydrate meal, they eat a sandwich, they, jelly bread, whatever it would be, and they raise their blood glucose level, and you never go there. Well, this condition called hypoglycemia unawareness is over time, and these type 1 diabetics over time, or insulin-dependent diabetics over time, their signs and symptoms change, and they don't recognize the change in them. And that's why some of these patients that, you've never seen, and they're like, well, this guy's been a diabetic for 25 years, and he always knew when he was becoming hypoglycemic. I don't know why he didn't recognize it. It's because their signs and symptoms changed. The patient's still looking for the old ones and didn't recognize the new ones. And that's why you're getting some of these patients who've been diabetics for years and they suddenly suffer this hypoglycemic event. It's called hypoglycemia unawareness. So what is our management? Okay, airway, ventilation, oxygenation. We know the normal routine. The main thing here is this patient who's hypoglycemic needs glucose. They need glucose. Now, again, most common, it's going to be a dextrose solution in water. Today, the most common solution that is being used is the D10W infusion, where it's a 10% dextrose infusion. And the way that you did the, most common way to do that is just take 250 mLs of normal saline and inject in 25 grams of 50% dextrose. That's going to give you a D10 solution, and you run it. And the reason why this is actually preferred is because it's a lot more easier to control. You're not overshooting the glucose. So you're running the D10, and once you get this patient to wake up, and you can recheck the blood glucose, they may not need the whole infusion. You can regulate it a lot better. And D50 is very viscous. It's acidic. If it extravasates, it'll kill cells too. So it'll kill tissue outside of that vein. So you have to be careful. If you can't get an IV line, you can give glucagon. Glucagon, again, it's a second line drug. If you have an IV line, if you have a IV line or an IO, I know you're moving away from IOs, especially in a hypoglycemic patient. But if you can't get an IV line, then you go with glucagon. Now, here's the thing. If you give glucagon, okay, so Matt and Larry are working the ambulance, and Larry's trying to get an IV, and Matt's like, all right, Larry. Larry's like, man, I stuck this person the second time. Man, their veins are so bad, because we know diabetic patients' veins are terrible because of the peripheral vascular disease associated with the high glucose and the atherosclerosis and so forth, metabolizing fat and mobilizing fat all the time. And Larry's like, man, I'm going to try again. And Matt says, well, you know what? I'm going to go ahead and give, I'm going to give her 1 milligram glucagon IM. You can give it intranasally. And Matt goes ahead, gives 1 milligram glucagon, because what do we know? Glucagon's not sugar. What's it got to rely on? It's got to rely on the liver to put glucose back into the blood. And then Larry goes, hey, Matt, I scored an IV. What's Matt going to do immediately once Larry gets that IV secured? Matt's going to turn around and he's going to administer a 10% glucose solution. Even if you give glucagon, you immediately, as soon as you get that IV line, you follow it immediately, because there's a lot of times where the glucagon's not effective because the body's already exhausted what's in the liver. So if you do give glucagon, and as soon as you get an IV line, you go ahead and you follow, unless your patient's awake. If they're not awake, you immediately follow it with your glucose. Okay. The SEMSO guidelines, basically, it's no different than we already said. And even this, like the adult dosing, 25 grams, pediatric dose 0.5 to 1 gram per kilogram. Okay. And you're always going to use 25 or D25 with the pediatric patient. But, right here, 250 mLs of 10% solution. Again, take 25 grams. mix in a 250 mLs of normal saline, shake it up, and you're going to go ahead and run that as an infusion. And the maximum field pediatric dose 0.5. This is not new to anybody. These are the standard doses. Newborns, you got to be careful. Newborn won't get anything more than a D10 solution too. But the way to go today, as most places are doing the D10, some have gone to 12.5 grams of 50% dextrose. Well, they'll give 12.5 grams, reassess the patient, give 12.5. And if they wake them up with 12.5 grams and their blood glucose is around 70 or 80, then they're okay. They're not going to give them any more. What they don't want you to do is overshooting the patients. Glucagon, again, 1 milligram IM. You could give an IN. Okay. Pediatric dose, okay, if they're greater than 20 kilograms, IM, IN, okay, 0.5 if they're less than 20 kilograms, okay. If the patient has a insulin pump, remove or disable the insulin pump if you can't do the above treatments. If you got the above treatments, okay, so here, for patients with an insulin pump who are hypoglycemic with associated altered mental status, GCS less than 15, stop the pump, disconnect, remove an insertion site if the patient can adjust oral glucose or ALS is not available. Leave the pump connected and running if able to adjust oral glucose and receive ALS interventions. So what that means is this. Now, this is NASEMSO. These are the physicians from across the country, medical directors of all the state EMS offices that got together and did these guidelines. These are still draft guidelines. They still haven't been finalized yet, but these are the draft guidelines, but these are the latest guidelines. What they're saying here is if you're a paramedic unit, you get on the scene and you're able to give glucose, 10% dextrose, you're able to give glucagon, then do not disconnect the pump, leave it run. But if for some reason you can't get anything, you can't get an IV line, you don't have glucagon, they're saying then disconnect the pump. For an EMT unit, if you can't get an ALS unit there and they have a GCS less than 15, they're saying stop the pump, disconnect the pump. Please don't cut lines and things like that, though. These are expensive. These are expensive devices. Okay. All right. Seizure might occur. What's going to happen if the patient has a seizure who's hypoglycemic? You do a blood glucose test on this patient. Their blood glucose level is 43. Now your patient starts to seize. What are you going to do immediately? Immediately, you're going to stop the seizure. You're going to give them benzodiazepam. In this case, the easiest thing to do would be to go ahead and give them midazolam, 10 milligrams IM, based on, again, that Rampart study that's saying that's as effective as 5 milligrams of diazepam intravenously, and then you're going to follow it with glucose. Make sure you give the glucose. Don't give the glucose as soon as the midazolam wears off. What do they do? Just go seize again because you haven't fixed the etiology of the problem. Make sure to fix the etiology of the problem. Okay. If the hypoglycemia, follow your protocol. Please follow your protocol. This is the recommendation by the state EMS offices across the country. I'm saying please follow your protocol, but they're saying here, if you treated the patient and the hypoglycemia resolves, the blood glucose is greater than 80, patient takes insulin or metformin to control diabetes, does not take a long-acting oral sulfonylurea agent, glipizide, glyburide, or others, the patient returns to normal mental status, no focal deficits. Patient can promptly obtain and will eat a carbohydrate meal after you've treated them. There's patients or legal guardian refuses transport, and the EMS, crew agrees. Reliable adult will be with the patient. They have no major comorbid factors, and it was a clear case of hypoglycemia. Then they're saying you could go ahead and release the patient. Document. Okay, and this is Trumbull's. I don't know, Larry or Matt. I don't know if you want to say anything about this.
No, that's the old one, but it's still true today. So what we're doing is, you have a hypoglycemic patient, and we're giving them the D10 just enough so they become alert and oriented and able to follow commands. At that point, we're documenting how many mLs of D10 we've gave them, and then we're waiting there with them until they eat a meal, make a sandwich, or something like that. And so that's what we're doing. So there's really no cut point for us to the repeating the glucose when we give the D10, as long as they're able to have a change in mental status for the positive and able to follow commands, then we're stopping that D10, having them eat in our presence, and then we're rechecking the sugar after the carbohydrates are on. So that's really what we're doing in versus the 250 mLs of D10 to titrate to get a sugar. So D10 works great. Most of the times, less than 100 mLs will change the mental status in the positive direction where you can have them eat. And yeah, it's great stuff. So,
Thanks, Larry. Matt, I don't know if you have anything to add. We'll jump in, but that's exactly why they're using D10, because it's so much easier to control. And as Larry said, you don't have to overload them on the glucose. The whole thing is nobody really knows how much 25 grams of D50 will raise blood glucose level. They estimate that it's about 70 to 80 milligrams per deciliter that'll raise it, but some people will raise it 140, some will raise it 20, so there's no magic to it either. And that's why, as Larry's saying, the D10, and that's absolutely the way that these places are doing this too. They run the D10 until the patient wakes up, and then they have them eat. They stop the D10 because you don't want to overshoot them. Diabetic ketoacidosis, 60-80% of current known diabetics. Look what's in red. 20 to 40% of diabetic ketoacidosis occurs as the first sign of diabetes mellitus. 20 to 40% of diabetic ketoacidosis is the first sign of diabetes mellitus in patients. So who's seeing that 20 to 40%? You are. So that means that in 20 to 40% of these patients, you're going to be the first person there, or the first person who's likely going to look at the family and say, this person is a diabetic. Their blood glucose level is off the chart. It's 600 milligrams per deciliter, and they have all the signs of DKA. So the point of this is, don't go to the scene and say, are they a diabetic? And the family says, oh, no, they're not diabetic. What's their medications? They have no medications. That implies they're diabetic. They have insulin. No, they don't take insulin. Don't go, well, like, okay, well, they're not diabetic, so this must not be diabetes. 20 to 40% of the patients, DKA is their first sign of diabetes mellitus, and you're the one who's finding it on the scene. So just because they have no history of diabetes mellitus doesn't mean a damn thing. You may be the first person who's actually finding this, okay? What do we know about DKA? There's not enough insulin. There's way too much glucose. These people, their glucose levels are sky high. Their blood is like syrup. They have not enough insulin. They have too little insulin. Why? If they're type 1, remember this typically occurs in type 1s, and in this case, they don't take their insulin, or their pump malfunctions, and they're not getting the insulin, but they continue to eat, and they eat, and their blood glucose levels going up. And then even if they're not eating, their cells are starving because they don't have the insulin. And so what are they doing? Their body's producing glucose by converting glycogen and then starting to convert fat into glucose and producing the ketones as a byproduct. Not enough insulin, too much glucose. What do we know about the brain cell, though? Is this DKA patient going to suffer an altered mental status within minutes? No. It's going to take this DKA patient hours, usually a day, 2 days, 3 days, before they suffer any type of altered mental status. Why is it? Their brain cells have more glucose than it knows what to do with. They're not going to suffer an altered mental status, and they're not going to suffer an altered mental status because they don't have glucose. Their brain's got more glucose than it knows what to do with. What's not happy? Well, the peripheral cell. The peripheral cell doesn't have the insulin to move the glucose in, has very little glucose. What's it doing? It's starving. It's starving. It's starving. It needs glucose. Send me glucose. Send me glucose. What's the body do? Revs up, revs up, revs up, okay? And starts trying to produce glucose to send it to the cells. All it does is raises the blood glucose level even higher. There's not enough insulin. So in diabetic, remember I told you right off the first slide, actually second slide. Remember I said, anytime you see the term diabetic, what do you think? Somebody tell me. Anytime you see this term diabetic, what do you think? Somebody tell me. Open your mic. Tell me. Somebody. What does diabetic mean? Come on, Lauren.
Excessive urination.
Excessive urination. Thank you. Who was that? Who was that?
Jessica.
Jessica. Thank you, Jessica. Excessive urination. Yes, excessive urination. Look at this. Look at this condition, diabetic ketoacidosis. By just looking at the term diabetic, what signs and symptoms am I looking for? Well, there's excessive urination. That's the pathophysiology, a part of it. But what am I looking for immediately? Signs and symptoms of what? Dehydration, dry skin, the dry mucosa, the furrowed tongue, the in severe cases, the hypotension, the tachycardia. Okay, all the signs of dehydration. Okay, what do I know right off the bat? Without even if you knew nothing about this condition right now, what do you know what treatment's going to be? Fluid. They need fluid because the term diabetic tells me they're peeing off too much fluid. They're going to be dehydrated and they need volume. What volume? Normal saline lactated ringers. Ketoacidosis. What do I know? They're going to be in a metabolic acidosis from what? Ketones. Ketones are strong organic acids. And so therefore, those strong organic acids are going to cause a ketoacidosis and their pH level is going to go down, make them metabolically acidotic. So right off the bat, what are two of the major problems we're going to be dealing with these patients? They're going to be severely dehydrated and they're going to need fluids and they're going to be in a metabolic acidosis in which we're going to have limited control over what we do about the metabolic acidosis. But those are two major conditions. And again, if you just look at the name, it tells you what you're going to be dealing with. So these patients have what's called osmotic diuresis. That is nothing more than what we already talked about. That big glucose molecule is getting spilled out in the urine because it can't all be reabsorbed. Remember, anything over 180 starts spilling off. Anything over 225 milligrams per deciliter, they start spilling off large amounts of glucose, and that glucose is taking the water with it. They got polyuria. They keep urinating, and the higher the glucose level goes, they urinate more, they become dehydrated more. You see more severe signs of dehydration. That means they need more fluid. And then because the insulin's not in their body, it's not being circulated, they're not getting the insulin because they either didn't take it, their insulin pump failed, they ate way too big of a carbohydrate meal compared to the amount of insulin that they're taking. What happens? They don't have the insulin to get the glucose into the cells. Brain cells are thrilled to death. They're happy. Peripheral cells are starving. They keep telling the brain, I'm starving, I'm starving, I'm starving, because they're not getting the glucose. And so what does the brain do? It says, we need to produce glucose. We need to produce more glucose. We need to produce more glucose. There's no more glucose left in the liver. So what does it start doing? Starts sending fat to the liver. Liver starts burning the fat, or converting the fat in an attempt to make glucose. It starts producing mass amounts of ketones, which are organic acids, which now starts making the patient metabolically acidotic. Now, anytime that you have an increase in urine output, whether it's diabetes insipidus, whether it's diabetic ketoacidosis, whether it's an excessive amount of urination because of a diuretic, whether it's excessive urination because of, I don't know, some other condition, you lose electrolytes. Well, in this case, remember, you're using sodium to buffer the ketone, so you're losing sodium. And the sodium is drawing water along with the glucose, but at the same time, you'll start losing potassium, magnesium, and you start now screwing up the electrolytes. The key here is you have electrolyte disturbance. And if you have an electrolyte disturbance, what comes along with electrolyte disturbance that we're worried about? Cardiac dysrhythmias. Now, cramping, obviously, we're not so worried about cramping, but it's the cardiac dysrhythmia. So what are your major problems in the patient who has DKA? They're severely dehydrated. They're metabolically acidotic. And remember, metabolic acidosis depresses cardiac function. The inotropic effect, okay, makes the heart irritable. It causes enzymes to dysfunction. It doesn't allow for normal neurotransmission and things like that. And they have electrolyte disturbances, setting them up for what? Cardiac dysrhythmias. Okay, so we got some major problems going on. Okay, and these are some of the reasons, why patients may suffer diabetic ketoacidosis. I don't think that's new to anybody. So what are the signs and the symptoms? And all of these could be explained. Why are they urinating so much? Because they're spilling glucose off to the urine. Why are they thirsty all the time? Because they're dehydrated, because they're spilling off so much glucose into the urine and the water's going with it. Why are they hungry? Because their peripheral cells are starving, because they don't have enough insulin in their blood to get the glucose into the cells. They may suffer nausea and vomiting dehydration as a result of the polyuria, hypotension, especially orthostatic hypotension, as a result of the dehydration. Kussmaul's, DKA patients will have Kussmaul's respirations. Kussmaul's are the deep rapid respirations. Now here, the acetone is one thing you might smell on the breath too. You notice and the acetone is one of the ketones, and only a very small amount of acetone can be blown off. Otherwise, the beta hydroxybutyric acid, acetoacetic acid, and the acetone has to be urinated off. But you get a small amount in the breath. This is interesting. Only about 50% of people can smell acetone. So if your partners are going, do you smell that? It smells like juicy fruit gum. Do you smell that? Or, you know, nail polish remover, whatever. And you're going like, what are you talking about? And you're like, you smell that. Can you smell that? And you're like, hey, those of you who've been on DKA scenes where they have the acetone breath, I tell you what, as soon as you walk in the house, you're like, that's a DKA patient. You know, it's like those GI bleeders with that odd, sweet, weird smelling, you know, bloody diarrhea. It's like, it's just that weird smell. Anyway, so why the Kussmaul's respirations? Well, we know if we take water and we combine it with CO2 at the bottom of the slide here, it forms carbonic acid, right? So we have to have a molecule of water and a molecule of CO2. We combine them together, forms carbonic acid. Well, then the carbonic acid is split into hydrogen, it's split into bicarbonate. And the bicarbonate is the primary way that is actually transported into the blood until it reaches the lungs, and then to recombine into CO2 and water, blow off the CO2. Well, in order to form carbonic acid, you have to have CO2 available. That means if you don't have CO2 available, you form less carbonic acid in the body. That means if you have less CO2 available, your carbonic acid level is going to go down. Well, because this patient has ketones, ketoacidosis, and the metabolic acidosis is going up because of the ketone acids are going up, the pH is going down, meaning they're becoming more acidotic. But as the ketone levels are going up, you say, well, how can I buffer this? Well, if I can drop the carbonic acid level, that means I can allow the ketone level to go higher without disturbing the pH as much. And so what happens? So the patient, this is not known, nobody trains them. This is all done subconsciously. What do they start doing? They start breathing deep and full to do what? Eliminate CO2, because if they eliminate CO2 through deep breathing, full breathing, they can't do what? Make carbonic acid. So what happens? As the organic acid level is going up, the carbonic acid level is going down, and their pH is somewhat stabilized. Blood glucoses are usually over 350. Muscle cramps because of electrolyte loss, abdominal pain because of the electrolyte loss. Kids a lot of times will complain of right upper quadrant pain, and that's because of the liver capsule. The liver actually becomes somewhat, I don't say inflamed, but enlarged, and it actually stretches the capsule. Kids especially will suffer right upper quadrant pain. Skin's warm and dry because it's dehydrated. ECG changes from the electrolyte disturbance, and tachycardia from the dehydration. And this, again, look at you, diabetic, signs of dehydration, signs of metabolic acidosis. Because you're peeing off so much, you're going to have electrolyte disturbances, and that's all these signs and symptoms. Okay, so what's the key? Diabetic, they're dehydrated, they need volume. Ketoacidosis, not much we can do about it, okay? Our main treatment in the DKA patient is rehydration. Our main focus is supportive care and rehydration. We can rehydrate them. That is the key in any of these DKA patients, rehydrate them. Okay, IV normal saline, 1 to 2 liters over 1 to 3 hours. Children use a 20 ml per kilogram bolus for the first hour. Again, adults, we're not doing the weight-based dose. Kids, we are. Put them on a continuous ECG monitor, SpO2, end-tidal CO2, you know. But the key with that patient is to rehydrate. Now, hyperglycemic hyperosmolar non-ketotic syndrome, or HHS, hyperglycemic hyperosmolar syndrome. I like the non-ketotic because that tells you a huge thing in the name. Okay, look at the name, hyperglycemic. What do we know? Blood glucose level is going to be elevated. Hyperosmolar, what's happening? Well, there's too much glucose in the blood, so it's drawn in fluid. And if there's too much glucose in the blood, once it gets into the distal tubules and into the collecting ducts, it's drawn in water. So what are they going to have? Mass amounts of urination. Non-ketotic, though, they remain non-ketotic. They're not producing mass amounts of ketones, okay? HHS patients, HHNS patients are common patients, very common in nursing homes. These are usually patients that are elderly, but they don't have to be elderly, but these are usually patients that have some type of debilitating condition or disease. These are patients that have been traumatized, strokes, cancer, whatever, and they're in nursing homes, okay, a lot, or long-term care facilities. And again, this may be the first time that that you're seeing this, but again, keep in mind these are type 2 diabetics. They're not type 1s, they're type 2s. Type 1s go DKA, type 2s usually go HHS. So the hyperglycemic, look at their glucose, is 600, 1200 milligrams per deciliter. I read one case where it was 6,000 milligrams per deciliter. They have a hyperosmolarity condition because they have so much glucose in the blood, okay, that again, it's drawing the fluid into the blood, it's drawing it into the collecting ducts, and they're urinating off mass amounts of glucose. Oh, wait, let me go back. One thing here. Why is it that your DKA patient eventually suffers an altered mental status? Why does it take 2 to 3 days, a day, 2 days, 3 days for the DKA patient to suffer an altered mental status? We know it's not because of the brain having not enough glucose, because in DKA, their BGLs are greater than 350. What do we know? Their brain got more glucose than it knows what to do with. So why does a DKA patient eventually suffer an altered mental status? Remember, hypoglycemia, within minutes, boom, lose the glucose, the patient has an altered mental status. DKA, maybe a day, maybe 2 days, maybe 3 days, maybe 4 days before these patients start suffering an altered mental status. Why is that? 2 reasons. Anybody tell me? 2 reasons. No? Come on.
Does it have anything to do with the water transport and the excessive sugar?
Well, remember, the excessive sugar is actually feeding the brain, but the water transport, yeah, because the water transport, where's it all going? They're peeing it all off. And so what happens? The brain becomes what? Severely dehydrated. When the brain becomes severely dehydrated, it starts to dysfunction. And then the second is when the brain becomes severely acidotic. So the reason why the DKA patient eventually suffers an altered mental status is not from a lack of glucose because their brain got too much glucose. It's because the brain becomes severely dehydrated and it becomes acidotic. Okay? So in the HHS patient, they'll suffer a decreased mental status too, but you'll find it's not from acidosis, it's from dehydration. Ketosis and acidosis is minimal. Okay, so why is that? What do we know? HHNS typically occurs in the type 2 diabetic, right? What do we know about the type 2 diabetic? The type 2 diabetic, their pancreas still functions and they still secrete insulin. It might not be enough and it might not be a real active insulin. The insulin receptor sites might not be real active, but they're still secreting insulin. And what does that insulin do? It's enough insulin to get enough glucose into the cells, okay, to keep the patient from burning mass amounts of fat. Instead, they supplement a little bit with amino acids. So they're not burning all this fat, but at the same time, they're converting amino acids and the blood glucose level is going up. But that's how they remain aketotic and not acidotic, but they still suffer the dehydration because they still have mass amounts of glucose. Okay. And that's how, because they actually are still have enough insulin to get little amounts of glucose into the cells to keep them from the starvation mode. Believe it or not, this has the highest mortality rate. Out of hypoglycemia, DKA, HHS carries the highest mortality rate, and that's because these people usually have severe comorbid factors. Brain cells are great, peripheral cells, getting some glucose. They're not starving, but at the same time, you got mass amounts of, here's that right here, relative peripheral tissue amino acids, okay, causing hyperglycemia, causing severe osmotic diuresis, causing severe dehydration. So the problem with the HHS patient is severe dehydration, but they don't have the metabolic acidosis because they're not producing the ketones. And again, elderly is most common with NIDDM, the type 2. 20% have no history of being a diabetic. It could occur in children with IDDM, but usually they have some type of pre-existing condition. Okay, these patients, extreme dehydration. Now, again, these patients, again, their brain has a ton of glucose. So it's not the glucose that's causing this patient to suffer an altered mental status. It's not the brain, because the brain's got, well, it's not the lack of glucose to the brain. This brain's got a ton of glucose. What are they suffering the altered mental status from? Excessive dehydration. They become severely dehydrated. And again, usually by the time you're seeing these patients, they're going to tell you they have oliguria, very scanty urine. And the reason why they have oliguria, because they already urinated all their volume off, but they're also going to be hypotensive, tachycardic, altered mental status. You're going to see severe signs of dehydration. So orthostatic hypotension, tachycardic, fever may occur, marked dehydration, average fluid deficit of 24% or 9 liters. So they've been dehydrating their interstitial space, intracellular space, altered mental status, dizziness, confusion, polyuria if it's early, oliguria if it's late. If you're seeing oliguria, they're going to have a severe altered mental status. You're going to see hypotension. You're going to see significant tachycardia, really dry skin, really dry mucosa. Seizures may occur, hemiparesis, dry warm mucosa, dry warm skin, poor skin turgor. Skin turgor, you know, when you check the skin turgor, it's usually patients over 65 that, you know, it's like, don't even check it in them, because their skin becomes pretty inelastic and it doesn't tell you anything. If they're younger than that, you could check skin turgor. Believe it or not, the best place to check skin turgor, especially on kids, is on the chest, believe it or not. Polydipsia, they're going to be thirsty because urinating off, nausea, vomiting, confusion, weakness. These are all signs and symptoms of the HHS. So HHS, what's the main thing here? Severe dehydration. Keep in mind, just look for severe dehydration. And how are you going to treat them? Rehydrate them. Fluids, rehydrate them. 2 to 3 liters over several hours. Okay. You know, again, they're check the blood glucose level, obviously. You should be checking blood glucose levels on anybody who presents with any altered mental status. It doesn't matter what it is. Any altered mental status, check the blood glucose level. If they do happen to have a seizure, again, treat it with your seizure protocol. Again, hopefully it's midazolam, 10 milligrams IM. You know, if not, follow your seizure protocol. So this is just some of the this is the Nasemso stuff. There's nothing really different. The only thing I want to point out here is that the Nasemso guidelines actually they do have calcium gluconate or calcium chloride in it, and the reason why calcium is given, it's more or less because one thing I want to tell you again is again, cramping may occur in this patient because remember, anytime you have any condition which you're urinating off large amounts of volume, you're going to lose electrolytes. Okay, but here's another problem. And this is, let me go back. This is actually for the DKA patient. This is kind of weird the way I did this. This is for the DKA patient. Okay, this isn't for the HHNS patient, because the HHNS patient, again, they're going to be severe dehydration. But again, the HHNS patient could, again, this would fit for them too. But this is primarily geared to the DKA patient. And so the problem is with hyperkalemia. So what happens is when you have a large amount of glucose in the blood, in the interstitial fluid, and so forth. What do we know about potassium? Potassium is the primary intracellular ion, right? And so when you have a large amount of potassium, where the potassium should be inside the cell. When you have a large amount of glucose in the interstitial space and in the intravascular space, what happens is it has a tendency to draw the potassium out of the cell. So all of a sudden, when you start drawing the potassium out of the cell and into the interstitial space and into the intravascular space, what happens? The potassium level goes up. And we all know, there's one good way to murder somebody is give them potassium, because you're going to put them in a VFib. So hyperkalemia and hypokalemia are very arrhythmogenic. Hyper and hypokalemia are very arrhythmogenic. And the rhythm that it causes most often is ventricular fibrillation. And so that's why they're saying if you find signs of hyperkalemia, and primarily what you're going to find is severe signs of DKA, okay, and peak T waves on the EKG. If you're seeing peak T waves, that's going to be an indication of hyperkalemia. They're saying in the Nasemso, go ahead and give calcium chloride 1 gram or calcium gluconate 2 grams, okay? And And then they're saying at the same time, if you find hyperkalemia too, then you could give sodium bicarb, okay, too. They're recommending sodium bicarb, okay, at 1 milliequivalent per kilogram, okay, max dose of 50 milliequivalents over 5 minutes. Can consider albuterol because of the beta effect. But here's the thing. So the calcium gluconate or calcium chloride will not change the potassium level. So calcium gluconate, calcium chloride is not going to change the potassium level. But what the calcium is going to do, it's going to protect the heart, okay? So it doesn't do anything with insulin. It doesn't do anything with the potassium, okay? But what's going to happen is the insulin is going to move the potassium from the blood into the cells, and then it's going to lower the potassium level again once you get insulin on board. So what I'm saying is calcium gluconate or calcium chloride doesn't change the glucose, and it doesn't change the potassium. The only thing that's going to change the hyperkalemia in the DKA state is going to be insulin. Because once you get insulin on board and you start moving that glucose back into the cells, the potassium is going to go back in with it, and the potassium level is going to go down. But what calcium chloride or calcium gluconate is going to do, it's going to antagonize the cardiac effect of the hyperkalemia. So because the hyperkalemia is going to be arrhythmogenic, what it does is it raises the cell depolarization threshold, and it reduces myocardial irritability. So, and it doesn't matter. It doesn't matter what the calcium levels are. Really doesn't matter. If you have a patient in DKA and you suspect they're hyperkalemic in DKA because the potassium, hyperkalemic because the potassium is being pulled out of the cell by the glucose. Again, Matt and Larry could address this with the orders and so forth, but this is something they may consider, and that's given calcium gluconate or calcium chloride. Again, it's not going to touch the potassium. Now, sodium bicarb, however, on the other end, sodium bicarb actually can lower the serum potassium level. And what happens is when you give sodium bicarb, it actually raises the pH. And if you go back to that H2O plus CO2, the carbonic acid, and so forth. Okay, so if we give sodium bicarb, what we're going to do is we're going to produce a lot more CO2, and you're going to blow it off. And by doing so, we're actually going to elevate the pH. So if you elevate the pH with sodium bicarb, it causes the hydrogen ions to be released from the cells. And then what happens is this is accompanied by potassium moving back into the cells to maintain electron neutrality. So what happens is, so if you give sodium bicarb, you raise the pH, making it less acidic. It'll cause the hydrogen ions to go back or to be released from the cells. And then what happens is, because they're being released from the cells, the potassium has to move back into the cell to maintain the electron neutrality, and therefore the serum potassium level goes down. So calcium chloride, calcium gluconate doesn't change the potassium level. It protects the irritability of the heart. Sodium bicarb, on the other hand, actually does protect, or doesn't protect. I'm trying to rush. Sodium bicarbonate actually reduces the potassium level. So why doesn't EMS administer insulin? This is a question I used to get all the time. When I used to teach, when I used to lecture, all over the country, and people say, well, why won't they let EMS give insulin? Well, the main reason why they don't want EMS administering insulin is because of the potassium issue. Because, again, we know that potassium levels, whether they're low or high, are so arrhythmogenic that you really have to monitor closely the potassium levels when you're giving insulin, because there's this correlation between the insulin, the glucose, and the potassium, okay? And so that's the main reason why the EMS isn't giving insulin, because we don't have the ability to manage or monitor the potassium. And that's the primary reason why that we're not doing the insulin. Me personally, I wouldn't want to do the insulin because, I'd rather my patient, I rehydrate them, I take care of their hydration issue, get them into the hospital, instead of dealing with a patient who's now in VTAC or VFib, because I actually gave him too much insulin, didn't give him enough, whatever it would be, and now I screwed up the potassium level. So that's why insulin is not given. Okay. Any questions? Anything? nobody's going to ask a question because everybody's like, I need a break. For God's sakes, give me a break.
I have a real quick question. This is
Yes.
Jenna Reyes.
Yes, Jen.
It was just for my curiosity,
Yes.
with the kidney failure with these patients, and it's such a high, number of patients who are diabetic that become, ultimately on dialysis from the kidney failure. Is it just because of the overwork of the kidneys, because of peeing off so much, or is it because of also the acidosis is killing the kidneys as well?
Well, a lot of it has to actually do with the high glucose level that starts to damage the tissue and filtration and so forth. So it's like even the neuropathies that the patients actually suffer, like the peripheral neuropathies, like how they can't feel like anything in their hands and their feet. It's because the high glucose levels will deteriorate that myelin sheath, and so it starts damaging the nerves. And like there's a couple things like peripheral vascular disease too. And if you think about it, why is it that a diabetic patient, and again, right away, if you have a patient sitting there and they got these huge open sores on their feet, and they're missing toes, and you don't even have to ask them a question. You're like, you're type 1 diabetic. And they go, yeah, how'd you know? And look at your feet, you're missing toes, you have these open wounds that won't heal, and so forth. And that's because these patients are constantly having to mobilize fat for energy. And so they have terrible atherosclerosis and arterial sclerosis. And again, that high glucose level that's constantly in the blood has a tendency to damage. And so those are some of the other things. The high glucose will damage the glomerular filtration system, and also the decrease in renal artery flow from the severe athero and arterial sclerosis too will cause the kidney dysfunction. Yeah, and it's the same thing like with the retinas, the blindness and the poor sight that occurs in diabetics. It's because the retinas are damaged by the high glucose too. So,
Okay.
and plus you get a decrease in retinal artery perfusion too. Yeah.
Thank you.
Yep, you bet. All right, Larry, Matt, what do you want to do? Be back at 8:10, 4 minutes.
Yeah, it's totally controlled by you. I know a lot of the comments and feedback have kind of questioned the overage time. So you're dictating this today. So if you're still in the room, take a couple minutes, 4 minutes, raise your hand, and we'll come back at what, 8:10?
8:10, yeah.
4
Sorry,
minutes. Okay,
guys.
great.
Hey, Joe, just want to let you know I was listening when you asked that question, but I had a mouthful of dinner. Katie's chicken came out delicious.
Oh, Dave. Oh, good. Yeah. Oh my God, Dave will know this. Yeah.
Dave, you didn't know anything.
She outdid herself.
Ralph. Yeah. Ralph only knows about beer. Yeah.
Yeah, where are all those questions?
Seriously, Ralph. I mean, seriously, I actually considered opening a beer and drinking it tonight. I'm like, oh yeah. I wish I could sit here, smoke a cigar, and drink a bourbon, but I think that'd be inappropriate. So
I described a lot of causes for a hangover tonight.
yeah, I'm still not. Yeah, I still got this crud though, Dave. It's like I keep looking at these cigars, going, man, that looks so good, but I'm afraid I would I'd probably be coughing like crazy. I was like, I just wouldn't enjoy it. So as soon as I get over this crap, I'll have to go smoke one. Ralph, you're welcome too, man.
All right, maybe I'll come over, but I'm not smoking. But thanks
Yeah.
for the offer.
Yeah.
All I know is I saw Joe and diabetics, and I had to break out the bourbon for tonight.
Well, Justin, at least it wasn't anything more hardcore like some illegal drugs or something, Yeah.
Well, yeah. I mean, no, it's just a Henry McKenna 10.
Oh, yeah. There you go. See, we got to get together. We got to have a bourbon night. Absolutely got to do a bourbon cigar night.
Yeah, count me in.
What do you think, Dave? Open the cigar barn up,
That sounds good, especially
Yep.
with the snow falling now.
Yep. Heck yeah. Move some stuff around. Oh, yeah.
I'm back in town every weekend, Joe.
I'm going to do it because I know Josh McHenry and Connor, they're hollering. We keep saying, we got to do this. We got to do this. We got to do this. And yeah, we'll do it. I'll put a thing out and we'll get a group together that want to smoke a cigar and drink some bourbon, and everybody come over. We'll go out into the woodwork shop that Dave and my Dave and Jim, my son-in-laws call the cigar barn, you know. So, but I don't think I could talk Andrea and let me smoke cigars down here. I don't know, you know. All right, I gotta refill my water real quick.
Is anyone else having trouble raising their hand or pulling up the comments? I can't seem to do it.
Only you, Ralph.
Great.
Ralph, make sure you're not like rejoining the group. You have to like relog in.
I did.
through the
Yeah, I
link.
did have to
Go
rejoin
back.
it. I accidentally hit the thing and got kicked off.
Yeah, if it says to rejoin it like through Teams, you can't comment anything.
Oh, okay.
Yeah, you
All
have to
right.
go back to the email, go back to the link, and then re-click it.
Oh, that's what I did. That's how I came in.
Oh, then I got nothing.
All right. I'm here, Larry, Matt.
Yeah.
Yeah, just so you guys know, every time you log in, Microsoft Teams takes an electronic footprint. So we know everybody who logs in, their times, how many times, Ralph, you've connected tonight. So when you guys leave, when you don't participate. So Microsoft Teams does a good job of tracking attendance. And remember, for everybody on this call, that the in-person live lectures count towards live training. If you're watching them virtually through the Google Classroom, those may be considered distributive education credits. So the National Registry has waived distributive education credits. The state of Ohio technically has not. We're going to get more clarification from the states tomorrow, and we're going to give you some more updates. So, you know, like I said in my email, 230 some participants registered, and even though we said you can watch them at your leisure, to get live training credit hours, as the state of Ohio suggests or wants, you should be in these live lectures. So just keep track of which ones are distributive, which ones you're joining in live, and we will give you all the certificates for your live logins as we get forward. So questions, just email me or Matt. I'll let Joe get back to it so we can finish somewhat on time.
Okay. Yeah, Larry, like my mother, Larry's texting me. I just looked at my phone. 8 p.m. time check. Okay, Larry, you know, God damn it, Larry, seriously, you know. And then Matt, smoking a cigar is inappropriate, but a gorilla pissing in its own mouth is okay. that cracked me up, Matt. I had to say that out loud. Anyways, all right, let's go. So immunology, anaphylactic and anaphylactoid reactions. Okay, I'm gonna move through this fairly quickly because again, you've all been through this. Again, it's more of a level of understanding and focusing on. This one focuses a lot on you know, recognizing what's going to kill the patient and how do we treat it so they don't die. So that's what this is going to focus on primarily. So an anaphylactic reaction is it's a misdirected immune response. It's not normal. It's misdirected. It's a systemic reaction, meaning that it's involving multiple organs or organ systems. So if you have a reaction that's only affecting like one part, it's not an anaphylactic reaction. That would be an isolated reaction. It may be an antigen antibody reaction. If it is an antigen antibody reaction, the IgE antibody, the immunoglobulin E antibody, is the primer for the reaction. And if it is an IgE antibody reaction, the individual usually has to be sensitized, and then chemical mediators are released, and it's life-threatening. So those are just some of the key things to an anaphylactic reaction. But I'm also going to talk about anaphylactoid reactions too, which again, you're going to deal with a lot of anaphylactoids. And the reason why I distinguish between the two of them is especially in your history taking. And again, another thing that, you know, Matt says again, it's funny, Matt, every time I do this, it's like, here's another thing Matt is right, that, you know, we beat into your head that oh my God, in order for a patient to have an anaphylactic reaction, they had to be sensitized to the substance. It means they had to be exposed to that substance sometime in the past. Not true. It's absolutely not true. These are the different types of hypersensitivity reactions. What we're most concerned about is the type 1 reaction, okay? IG or IgG mediated, most common, most typical anaphylactic reaction. And then we have direct histamine releasing reactions too, and that's going to be your anaphylactoid. Okay, so definition of anaphylaxis, acute cutaneous or mucosal involvement after antigen exposure, plus there's a respiratory compromise with bronchospasm, stridor, hypoxia, cardiovascular compromise, hypotension. Main thing I want to say here is you look at these. Okay, one thing I want to point out now, what they found actually most, and this is true in the latest literature, what they're finding is that people that are suffering an anaphylactic reaction that's to a food substance, they're finding that a lot of these patients are not presenting with skin signs and symptoms. That means that these patients that are actually having full-blown anaphylactic reactions to like shellfish or, you know, whatever, clams or whatever it would be, that's ingested, they're not showing, they don't have the massive hives and, you know, the urticaria, the pruritus, the itching, and the, you know, angioedema and things like that. What they have is they have major GI signs and symptoms. And so I just want to point that out. But, you know, otherwise, most often what you're going to find is the overt cutaneous signs and symptoms, mucosal involvement. The mucosal involvement is angioedema. That's where it's the swelling of the tongue, the swelling of the lips, the swelling of the oral mucosa, you know, and so forth. And then, you know, the urticaria, the hives, the itching, the pruritus is the itching, the urticaria, the hives. Then the respiratory compromise, the bronchospasm from smooth muscle constriction. Stridor is going to be associated with increase in capillary permeability, severe hypoxia. Cardiovascular compromise to the point where the patient can be hypotensive. There is also some of these chemical mediators are going to cause direct myocardial depression. You know, some cause coronary artery thromboxane. A2 causes coronary artery constriction and things like that. And then persistent gastrointestinal symptoms, vomiting, cramping, abdominal pain. We'll talk about these, but if you look at this, you say, well, you know, how's your patient going to die? Well, they're going to die primarily because of a respiratory compromise or cardiovascular compromise. They're not going to die from a persistent GI problem. They're, you know, they may suffer dehydration and electrolyte disturbance from, you know, diarrhea and vomiting and things like that, but they're going to die from a respiratory compromise or from a cardiovascular compromise. Okay, treatment indicators. And I put this in there, and this is the SEMSO. This is interesting because this actually is very, very important in saying, okay, and this is kind of what we're talking about treatment already, but you know, I'm gonna get into this, but this is extremely important. So we're saying in an anaphylactic reaction, it's an acute onset, and you're going to find most of these reactions occur within minutes of exposure to whatever it is that they're exposed to that's causing the reaction, whatever the antigen may be, whatever the direct histamine or direct chemical releasing substances. They're gonna within minutes, but it's usually within 30 minutes that they actually suffer the reaction, and you're going to see the skin signs and symptoms, okay, or maybe not, with respiratory compromise, okay. Hypotension is defined as the systolic blood pressure less than 90, or signs of end organ function, or hypotension after exposure to a known allergen. So this is just what NSEMSA put out there as like kind of like a treatment guideline. But this one actually is actually more important to look at, because what they're saying is if you have two of these, so really what they're saying is if you have urticaria, mucosal edema, so if you have hives, the itching, swelling of the tongue, swelling of the lips, and you have respiratory compromise, you have wheezing, or you have hypotension, they're saying then treat this as anaphylaxis, give them epinephrine, the whole host of other drugs. Or if you have hypotension after exposure to a known allergen, you know, then you go ahead and you give them the anaphylaxis. But I like this one better. This is all still part of this from the SEMSO. They're saying, or if you have two of these, okay, any two of these, you say to yourself, this is anaphylaxis. So if you have the skin or mucosal involvement, the urticaria being the hives, the angioedema being the swelling, pruritus being the itching, or if you have a respiratory compromise being dyspnea, wheezing, stridor, hypoxemia, okay, or if you have persistent GI symptoms, vomiting, diarrhea, abdominal pain, abdominal cramping, or if you have hypotension, evidence of poor perfusion, any two of these, you would say, yep, anaphylaxis, they're getting EpiIM, and they're getting the remainder of the other drugs that we carry. They're getting the Benadryl, they're getting the cimetidine, and whatever else you're using, okay? So Any two of these is going to trigger you to say this is anaphylaxis and I need to treat it aggressively. On the other is obviously fluids too. Non-anaphylactic reactions, signs involving only one organ system. So localized edema, angioedema, like, you know, the face is swollen, but nothing else. There's no bronchospasm, there's no wheezing, there's no vomiting, there's no diarrhea, there's nothing else. Just facial swelling. That's a localized angioedema, you know, where it's a localized reaction. Now, the only problem is if it's angioedema at the level of the larynx, then you got a problem, you know. But again, just keep in mind that this is a systemic reaction. This involves more than one organ system. If it's just one organ system, here's an example. If you get on the scene and you suspect this patient is having an allergic reaction to something, and the only thing that they have is wheezing. It's the only thing that they have is they're wheezing, and they're saying, hey, I'm a little bit short of breath, and that's the only thing they have. They have no skin signs, they have no GI signs, they have no cardiovascular signs. That's it. You're not going to load them with a shitload of fluids. You're going to start an IV line for sure, large bore, and you know, you do want that just in case that this converts to something more serious. You're not going to give them epi, you know, IM. What you're going to do is you're going to treat them with a bronchodilator, is what you're going to treat them with, because it's an isolated reaction. It's obviously only involving the bronchioles, and so you're going to isolate that. Okay, so again, if they don't have two or more of these, you're not going to go the full-blown treatment. You're going to focus on whatever it might be. Okay, so you know what's going to kill these people? What is cause? So here, this is kind of interesting because I say, you know, these pathologic conditions that are created by the release of these chemical mediators, and there's a bunch of them, cause these pathologies to occur within the body. If you want to describe every sign and symptom, you could describe it based on these different pathologies. If you want to describe your treatment, you could describe it based on this pathology, okay? Every single sign and symptom comes back to this. Every treatment comes back to this, because what you're trying to do is reverse what's here, okay? And every cause of death comes back to here. So if you want to know how to keep your patient from dying, and how to treat them effectively, and why they're showing the signs and symptoms, you know, they're showing what to expect, you look at all these pathologies of chemical media release. There's an increase in capillary permeability. There's massive vasodilation, that's systemic. There's bronchoconstriction. There's an increase in mucus production. There's myocardial depression. There's coronary artery spasm. And there's stimulation in nerve ends, too, that you're finding that may be causing some of the nausea and some abnormal findings in the patient. But the main things here that you're really worried about are these top three. This is what's going to kill the patient primarily: an increase in capillary permeability, vasodilation, and bronchoconstriction. These are the three main ones that you really have to focus on reversing to keep this patient alive, okay? So increase in capillary permeability, what's happening? We're leaking out. So the capillaries become very permeable, and what happens when the capillaries become very permeable is they allow a ton of the plasma volume to leak out. If they become so permeable that albumin is leaking out, this patient is going to lose a ton of volume, okay? But what's happening here with increase in capillary permeability is the capillaries become open and become leaky. And the way that you reverse an increase in capillary permeability is you constrict the vessel, because when you constrict the vessel, you get rid of the leakiness, okay? Because you tighten it back up. You got to tighten the vessel up. How do you tighten the vessel? You got to constrict it. How do you constrict it? Primarily through an alpha drug. Vasodilation occurs systemically. So if you had a vessel that was the size of that vessel on the left hand of the screen, and all of a sudden now you got chemical mediators that are causing massive vasodilation, what do we know? You only have a certain volume to fill that space, a certain blood volume to fill that space. So all of a sudden, if we massively increase that space, you say, well, geez, we don't have enough volume in that space to maintain a normal pressure, okay? Our systemic vascular resistance goes down, our preload goes down, our cardiac output goes down because our stroke volume goes down, our SVR is down, our cardiac output's down, our blood pressure goes down. So all of a sudden, we have a hypotensive patient because we have a massively increased space. You say, well, how do I increase the pressure in that big space? Well, there's two ways to increase the pressure in that big space. This makes sense. I was like, one is fill the space with volume. So what's your treatment going to be? Fluid, and a lot of fluid. We're talking any anaphylactic patient should have 2 14-gauge angiocats with fluid running wide open, normal saline lactated ringers, okay, an isotonic solution. And the second way that you're going to actually increase the pressure in that space, you're filling the space, is decrease the space. Again, use an alpha, vasoconstrict, and by vasoconstricting and filling the space with volume, then what are you going to do? You're going to increase the SVR, you're going to increase the preload, you're going to increase the stroke volume, you're going to increase the cardiac output, and you're going to increase the blood pressure. Okay? Fill the space with volume and vasoconstrict. Okay? So why does this patient have peripheral edema? Why does this patient have edema in the feet? Because it doesn't matter where you're leaking the volume from, the gravity is going to pull it down. So you're going to find in anaphylactic patients, you're going to find not only is typically the face and the neck is very swollen, the upper chest, but primarily the face and the oral mucosa, the tongue. So, and the reason why that's all swollen is because it's extremely vascular. But then you're going to find that the hands and the feet are going to be edematous too. And you think, well, why the hands and the feet? Well, the hands and the feet because of gravity, and it's dependent edema. That fluid's being pulled down. So you're typically going to see the dependent edema. Here's the danger. If you look inside the mouth, now here's what I'm going to tell you. If you have edema in the hands and the feet, and you have edema to the face and the tongue, well, you know one thing, that oral mucosa that's surrounding the larynx and the glottic opening and the glottis, that's all edematous too. That's your major problem. We could care less about the fluid in the hands and the feet. They're going to reabsorb that. We don't really care so much about the swelling to the face. That's going to go down too. But the swelling that's occurring to the tongue that may cause an occlusion at the level of the oral pharynx or the hypopharynx. But now when you got swelling occurring there, you know one thing, you got swelling at the level of the larynx, and that's what's going to cause your laryngeal edema, and this larynx may actually eventually completely swell shut. This patient needs epinephrine immediately, and this patient may need intubation depending on how quickly you could get this reversed with epinephrine. But why epinephrine? Saying, well, because this is due to an increase in capillary permeability. This swelling at the level of the larynx that's causing laryngeal edema is directly related to an increase in capillary permeability. How do we get rid of the capillary permeability? We tighten the vessel. How do we tighten the vessel? We vasoconstrict. How do we vasoconstrict? An alpha drug. What's the best alpha drug we got with us? Epinephrine. Okay. That's
Joe, John Cameron had his hand up real quick.
Yes. Yes.
John, do you have a question?
Question, John?
Negative.
No?
I hit it
All
on
right.
accident. I'm sorry.
Okay.
Okay.
So this, if you're looking like almost like with the bronchoscope or maybe laryngoscope on the top, this is very difficult to see. This is the epiglottis here. This is the glottic opening here, but you can see the swelling here, the laryngeal edema. And okay, so what's the clinical sign of laryngeal edema? Stridor. Stridor is the clinical sign. You're going to have stridorous respirations where the patient, when they're breathing in and breathing out, you're going to hear that high-pitched sound coming from the larynx. That is a huge indication that should smack you in the head saying, this patient's got laryngeal edema. Keep in mind, don't think like, okay, you might say, Larry, get the intubation stuff out. Let's go ahead and get a number 8 tube, maybe a number 7 tube. I would normally put an 8 in. I might need a 7 or a 6 because this is so swollen. But let's get this epinephrine on board right now. Because why? Because if you get the epinephrine on board and you could reduce the increase in capillary permeability, you may actually take this laryngeal edema and eliminate it. So get that epi on board as quickly as possible. These are the urticaria. These are the hives. Hives are actually a result of an increase in capillary permeability that's occurring in the epidermis. If you see hives all over the body, you know what? This patient is leaking fluid all over the body. And if this patient is leaking fluid all over the body, there's a good chance of leaking in the larynx too. Okay. And bronchial constriction is going to occur. Not only is the bronchial going to become constricted, but the mucus glands are going to start secreting a ton of mucus. And this patient, because there's an increase in permeability, this mucus has a tendency to be real thick and sticky. So not only is the bronchial going to be constricted because of the muscle band around the bronchial, but it's now also the mucosal layer inside the bronchial is going to be inflamed, and it's going to reduce that internal diameter size. And then you got this real thick, sticky mucus that's going to block bronchioles too, the terminal bronchioles and so forth. So with bronchial constriction, this is very similar to your asthma patient, where you get the muscle bands constricting, you get the internal inflammation that's causing the bronchial to narrow on the inside, and then you get real thick, sticky mucus too. Okay. Fatal episodes, what's a patient going to die from in anaphylaxis? Number one, airway occlusion. What airway occlusion? Laryngeal edema. Laryngeal edema. What's going to be your immediate fix for laryngeal edema? Epinephrine. If you get the epinephrine on board and that airway is still edematous and you still got major stridor and you got a patient who's struggling to move air, your next step then is don't wait. You're going to go ahead and intubate. Okay. Again, follow your orders. But in this case, it is recommended that you try to get the epinephrine on board first. And again, what you might do is actually nebulize epinephrine too. Some systems use vaponephrine. Vaponephrine, you can nebulize regular epinephrine too. And the reason why you're nebulizing it is you want that alpha to be topically deposited right at the level of the larynx, and it gets absorbed right there in that mucosal tissue that's edematous from the capillaries leaking, gets absorbed, and those capillaries constrict, and then all of a sudden now that edema goes away. You know, here's the example. I don't know how many of you have ever used neosynephrine. In the old day, a lot of people would use neosynephrine, and it's got like a nasal atomizer on it. It comes that way, and all you do is you spray it up your nose. Well, neosynephrine, think about it: neosynephrine, epinephrine, norepinephrine. Neosynephrine is basically norepinephrine. It's primarily a all alpha drug. Neosynephrine they use in spinal cord injured patients. Actually, not they don't have them sniff it up their nose, but neosynephrine, Afrin, neosynephrine, the trade name was Afrin, and you would shoot it up your nose when your nose was all clogged. And you say, well, why was your nose all clogged? Because usually histamine from allergies and so forth. And what was the histamine causing? An increase in capillary permeability, okay, vasodilation. So it's increase in capillary permeability was causing your nose to do what? Swell inward. And when you would shoot the Afrin up your nose, the alpha properties would do what? Get to the capillaries, cause them to tighten up. And when the capillaries tighten up, it did what? Open up your nose and you're able to breathe. So it's kind of the same concept. Airway occlusion, though, is you want to get it to the level of the larynx. So again, give the IM injection of epinephrine. And if you're still having trouble with the airway and the patient's still able to move air, you might want to nebulize epinephrine or vaponephrine or racemic epinephrine at that point. The second reason is ventilation failure. They have massive bronchoconstriction at this point. Again, epinephrine has beta-2 properties. It's going to bronchodilate. Steroids have fallen out of favor. I do notice you guys still have steroids in there. I know places are still using them in anaphylaxis, but there's no empirical evidence that says steroids actually work in anaphylaxis, and the evidence-based people are saying take them out because there's really nothing that shows that they work. So you're down to basically albuterol and epinephrine. So nebula or IM injection of epinephrine with the beta-2 hopefully is going to take care of the ventilation. Ventilate your patient if they're in ventilatory failure and high oxygenation. You're going to use 15 liters per minute, maximize the oxygenation. Severe hypoxia, the severe hypoxia may be related to the airway occlusion or the ventilation failure, okay? And then hyperperfusion is going to be from cardiovascular collapse. The primary reason for the cardiovascular collapse is going to be the massive vasodilation. Again, if there's massive vasodilation, fill the space with volume. Two large bore IVs, lactated ringers, and normal saline, fill the space and get a pressure on board, okay? If you are filling the space and you're still struggling with the blood pressure, but the airway is good, the ventilation is good, you're just struggling with the blood pressure, you may want to consider an epinephrine infusion. You may want to consider dopamine at a high dose too to get the alphas. So IgE-mediated anaphylactic reactions or antigen-antibody reactions. That means there has to be an antigen and there has to be the production of an IgE antibody to react with the antigen. These antigens are introduced by injection, ingestion, inhalation, and absorption. Same way that poisons are introduced into the body. Here's how this works with the IgE reaction. Let's say that Larry's allergic to egg yolks. He doesn't know this. He's eaten egg yolks forever. And all of a sudden now he goes out to breakfast tomorrow morning by himself because he has no friends. And he eats eggs. And all of a sudden now his body now views that protein in that egg yolk as an antigen, okay? And all of a sudden now his body forms IgE antibodies to fight off that antigen. And these IgE antibodies actually physically attach to mast cells and basophils. And mast cells are found primarily in connective tissue. Basophils are found in the blood. Basophils will leave the blood and become mast cells in connective tissue as they mature. Once that IgE is attached to the mast cells and basophils, this patient now, Larry, is considered to be sensitized. Now, if those stay attached, the next time he eats egg yolk, all of a sudden, when that antigen in that egg yolk is introduced, it attaches to the IgEs. It's kind of like a Y. It attaches to the IgE antibodies on the mast cells and basophils, and it causes the cell to degranulate. And when the cell degranulates, all of a sudden, all these chemical mediators begin to get released. And when the chemical mediators released, they're actually absorbed in the blood, and all of a sudden now they hit their target cells, target organs, like smooth muscle, like the heart, like the bronchioles, like mucosal tissue, capillaries, and things of that nature. So this is an IgE reaction. This is one thing, like Matt has said, we used to beat in your head that in order for this patient to have an anaphylactic reaction, they had to have been exposed because they have to have been sensitized, and that's the IgE reaction. But they found that not all anaphylactic reactions are IgE anaphylactic reactions, okay? And this is the allergen here. This is attached. These are your antibodies here. And this is the antigen that actually attaches and causes the cells to degranulate. There's a ton of different chemical mediators. All I can say is with that cell degranulation, you're getting the release of the chemical mediators. I'm not going to spend a lot of time on this. And these chemical mediators are actually going to cause those things to occur that we said earlier. Increase in capillary permeability, vasodilation, bronchoconstriction, smooth muscle constriction, cardiac depression, coronary artery constriction, and so forth. Increased mucus. Those are all coming from those different substances. And they all do different things. Some do very similar things. A lot do similar things. Some have very specific, roles and so forth. But one thing I want to point out is, look, histamine is only one of these. Histamine is only one. There's a lot of other chemical mediators. What does that mean? Why isn't Benadryl our number one drug of choice? Because look, Benadryl will only block histamine, okay? It's not going to block all these other things. And so these other things have very similar effects as the histamine. If you only block histamine, you're not taking care of all these other chemical mediators that are spilling out into the body. Common IgE substances. These are common substances that a patient becomes sensitized, and then they have an anaphylactic reaction. Antibiotics, penicillin, tetanus, insulin, Hymenoptera or insect venom, vasopressin, streptokinase, glue, rattlesnake venom, deer fly, mosquito venom. It's rare. Some people are allergic to mosquito venom, have anaphylactic reactions. That would suck, really. A hypersensitivity to insects, to the Hymenoptera. Now, this is important. When a hypersensitivity to an insect sting is present, 35 to 60% will suffer anaphylaxis to a subsequent sting. So those people that say that they're allergic to bee stings or wasp stings, whatever it would be, and they carry an EpiPen, God, I hope they carry it with them. Look at this, 35 to 60% of them will suffer an anaphylactic reaction on being stung again. And these are the Hymenopteras, okay? Bees, vespids, stinging ants, okay? So it's not just things that fly to the ants too. Other IgE substances, other things that will cause the patient to become sensitized. Therapeutic agents, hydrocortisone, methylprednisone, thiazides, thiopate, acetaminophen, Tylenol. Somebody could have an IgE anaphylactic reaction from acetaminophen, latex gloves, egg-based vaccines, measles, mumps, rubella. I'll tell you this story. I was doing this lecture. I think it was out in Utah, Salt Lake City. And I said, anybody here? There's about 600 people. I said, is anybody here allergic to latex? And there's one little girl. It sounds so bad. One little girl. One young girl. But she was in smaller stature. That sounded so bad. But she was younger. She was probably about 20, 21 years old. And she was sitting there with her group, and she raised her hand. And I said, well, how did you know that you were allergic? And she says, I died. And I'm up on stage. There's like 600 people. And I said, you what? And she said, I died. And her fellow EMS people with her said, she died. She went into cardiac arrest. I'm like, what? Well, here they were getting ready for their Christmas party at the station. They didn't have balloons, and they decided to blow up latex gloves for balloons. Well, here she had a latex allergy. She obviously was sensitized before. when she was blowing up, went to blow up the latex glove, the powder in the glove, she inhaled it, had latex particles, bam, she immediately had a severe anaphylactic reaction. She inhaled the substance and she went into cardiac arrest. Fortunately, they had an ALS crew there who was helping set up, and they actually were able to resuscitate her. She literally died from a latex allergy. If you're touching patients and they start with latex gloves and they start ending up showing signs of dermatitis, quit touching them, change your gloves, okay? Food substances, milk, eggs, fish, shellfish, peanuts, especially Brazil nuts, almond nuts, hazelnuts, macadamia. Peanuts, are not that common. These are the most common ones that are going to cause. Macadamia nuts have a high incidence of anaphylaxis. Physical environmental factors, exercise induced. If you want an excuse not to exercise, I don't want to have an anaphylactic reaction. Cold induced. And some they just don't know what caused it. Now, anaphylactic versus anaphylactoid. An anaphylactic reaction is your typical type 1 IgE mediated reaction where the person has to be sensitized. It means they had to have been exposed to that antigen before. They developed the IgE antibodies. They then get re-exposed, and that's the one where you say, have you ever had this substance before? Have you ever taken this medication before? And that's the one where they're going to have had it before and be sensitized. There are anaphylactoid reactions. Anaphylactoid reactions are non-IgE mediated, meaning they never have had to have the substance before. They're type 1 reactions, meaning that they are typically systemic reactions. But what happens is when the substance is introduced in their body, it's a direct release of mediators, okay, from the mast cells and basophils. They don't have to have the IgE antibody on the mast cell or basophils. This causes a direct degranulation of the cells, and they have a full-blown anaphylactic reaction from never, ever having been exposed to that substance before. We should beat in students' heads. If you go to the scene and they tell you they've never had this drug before and you think they're having an anaphylactic reaction, they can't because they had to develop the IgE antibody. Not true. And that's called an anaphylactoid reaction. From here on out, it doesn't matter. Who cares? If you get on the scene and you go, they got skin signs and they got severe respiratory signs, this is anaphylaxis or anaphylactic, it doesn't matter. They're going to die if you don't treat them. Who cares if it's anaphylactoid or anaphylactic? All I want to impress upon you is anaphylactoids. These are the people that go in to have a test done and they're given dye and they have a full-blown anaphylactic reaction from the dye and they've never had the dye before, or they're given a med or whatever it would be. These are non-IgE. These are direct histamine-releasing agents, opiates, curare, radiopaque contrast media, for the test, dextran, thiamine, aspirin, non-steroidals cause anaphylactoid reactions. Aspirin and non-steroidals. You don't have to have ever taken an aspirin before. First time you take it, you can have an anaphylactoid reaction, full-blown anaphylactic reaction. All right, so what are the physiologic responses to the chemical mediators? This is angioedema right here. You see that lip is severely swollen. Angioedema is a deeper edema. Okay, it's a deeper edema. It's in the dermis and below. That's an angioedema. I'm not going to, spend any time on these. These are the different chemical mediators. You can see, here, this is the only thing I want to say is you have histamine being released, and histamine will hit H1 receptors, H2 receptors, H3 receptors of brain tissue. H2 receptors are primarily found in the gastric, in the stomach and so forth. H1, you're primarily finding these in smooth muscle, and these are causing those. But this is why the H1 is going to be treated with the Benadryl. Benadryl is always going to be given in this. Benadryl is not your first line drug of choice. Your epinephrine is, and then your Benadryl is going to be second. The H2, in order to block the H2 receptor, this is where you're going to be given the cimetidine and some of the H2 blockers, ranitidine and some of those. H3 we're not doing anything with, but a lot of systems actually will give Benadryl, and at some point they'll go ahead and give an H2 blocker too. This high molecular weight neutrophil chemotactic factor, the only thing I want to point out here is it lasts for several hours, lasts a lot longer than histamine, and it causes a biphasic reaction. The only thing I want to tell you is this, is be very prepared. Never let your guard down with an anaphylactic or anaphylactoid patient. You could have treated this patient and they're doing great, and all of a sudden now this patient goes from doing great and they suddenly crash again. Biphasic reactions they found are very common in anaphylactic and anaphylactoid reactions, And this is one of the chemical mediators that's causing that biphasic reaction because it outlasts the epinephrine, it outlasts the histamine, or it outlasts the Benadryl and so forth. So the only thing I can tell you is be very cautious, be very paranoid. This patient's going to crash again because a lot of patients crash again. Leukotriene, slow onset, 6,000 times more powerful than histamine. Why don't we only give Benadryl? Look at this, leukotrienes, 6,000 times more powerful, okay? Longer duration. Kallikreins produce kinins, bradykinin, 10 times more powerful than histamine. Law of the cardiovascular collapse comes from kallikreins. Prostaglandins cause smooth muscle constriction, increased capillary pressure. Again, a lot of these are repeated over and over and over, doing the same stuff as the histamine. Thromboxane, bronchoconstriction, pulmonary vein constriction. This is the thing. If you have a patient having an anaphylactic or an anaphylactoid reaction, make sure that you're listening for crackles or rolls, because this increase in pulmonary hypertension will increase the hydrostatic pressure in the pulmonary vessels and could cause them to have pulmonary edema. Platelet aggravating factor, okay? This may cause DIC in your patient. You may find that they start bleeding uncontrollably through every mucosal area, every, port, anything. Characteristics, severity depends on delivery. Parenteral, like an injection, is going to produce the most severe results because it's the most direct. The faster the onset, the more severe reaction. Okay, the faster the onset, the more severe reaction. Typically, the onset is within minutes, but it's usually within 30 minutes. So it means if you had somebody that was exposed to a substance and it's 3 hours later and they now start developing some hives, in general, it's a good likelihood this patient is not going to have a full-blown anaphylactic reaction. They might just need some Benadryl, whatever it would be. But if it's occurring within minutes, this is usually going to be a very severe reaction. And they usually peak within 15 to 30 minutes. That's when they're the worst, okay? Respiratory skid signs, early most common, because the location of mast cells and basophils in the connective tissue. Again, if it's a food antigen, if it's a food substance, typically it's the GI symptoms. They're not having the skin signs, okay? Patients who have asthma usually have bad reactions too. Here's another thing I want to point out. Mild signs and symptoms could progress to severe within minutes. You might be dealing with that patient and they're only having a little bit of wheezing, and they got a little bit of hives, a little bit of itching. You're like, oh, okay, I'm going to go ahead and I'm going to give you, albuterol treatment. I'm going to give you, 50 milligrams of Benadryl, nothing to worry about. Nah, don't even start an IV line, whatever, whatever. And all of a sudden, I want to tell you, these patients can go from being okay to a severe reaction within minutes without warning. You're doing great. Don't worry about it. Take your time. To bam, this patient's got a lethal anaphylactic reaction. Always be prepared. Always have your equipment. Don't take stuff outside. Carry it with you. Don't leave these patients for any amount of time, okay? Most fatalities occur within 30 minutes. A delay of hours to days may occur. And be aware of the biphasic or multiphasic reaction. You treated them. They're doing great. All of a sudden, boom, they crash again, especially the people with the long transport times. This is one reason why you don't see these anymore. They're called the twin jacks, and the twin jacks actually came with 2 injectors. And the reason why they started making the twin jacks is because, and these are one's an auto injector and one is a manual IM injection. And they did this because of the biphasic reactions. And most often the EpiPens are packaged this too. Okay. So skin signs and symptoms, the most common you're going to see urticaria is hives. Again, this is from an increase in capillary permeability. You see hives, there's an increase in capillary permeability. If there's an increase in capillary permeability, that means that the larynx might be edematous. That may mean that the bronchial mucosa might be edematous too, okay? Those are the things that are going to kill the patient, so look for those. Pruritus is going to be the itching associated with just the nerve ending stimulation, okay? These are hives from fire ants. It's not a very good picture. I just want to show you hives present very differently. These are hives. These are hives. Okay. These are hives. These are hives. This is a latex glove allergy. Somebody was touching him with a latex glove. These are hives. They look like, vesicles filled with fluid. These are hives. Okay. Angioedema. This is angioedema. Remember, that's a dermal edema. It's a deeper edema. It's a dermis and below. Typically, angioedema occurs to the face, the neck, the tongue, the larynx, and the hands and the feet. And this angioedema, it's edema. It's from an increase in capillary permeability. These are larger vessels that are leaking now. They're leaking under the dermis, and this is what's going to lead to your tongue swelling. That's going to include the oral pharynx. This is what's going to lead to laryngeal edema too. Might have some more than tingling too. This is angioedema here. You can see also the hives to the upper chest, the hives here. Okay, obvious swelling. This is not. This is her tongue is swollen. Okay, that's angioedema. This is angioedema here too. You can see obviously the hives. You can see the eyes. This is all edema here. Okay, from the deeper angioedema. Here again, nasal congestion. Why nasal congestion? Because of the increase in capillary permeability causes your nose to swell inward and causes it to become stuffy. So these patients a lot of times will have nasal congestion. Stridor is telling you you have laryngeal edema. If you hear stridor, you have laryngeal edema. You got to reverse the increase in capillary permeability. Rhinitis is a runny nose, and that runny nose is actually an indication that you have an increase in capillary permeability. If you have a patient who's hoarse, why are they hoarse? That is another indication telling you that that larynx is swollen. They're hoarse because their larynx is swollen, and when they try to phonate, the vocal cords are not able to vibrate like normal. If you got a patient who presents with hoarseness and stridor, I tell you one thing, you got to get epinephrine on board very quickly. You better have your intubation out, equipment out, ready to go too. Headache from vasodilation. Vasodilation, dilate the cerebral vessels, increase intracranial pressure within the cranium, you're going to have a headache. Flushed skin is early. Why is the skin flushed? It's warm, it's red, because the vessels are all dilated in the skin. So that nice warm red blood is all out in the skin. The skin's going to be red, it's going to be flushed. Later on, as that blood's sitting there and is deoxygenating and it begins to lyse and so forth, then the patient's going to look mottled. They're going to start looking cyanotic. Syncope may occur because of orthostatic hypotension, because of the vasodilation. Lightheadedness could be due to the orthostatic hypotension, the decrease in cerebral perfusion because of the hypotension, the loss of volume through the increase in capillary permeability also could be due to the hypoxia too. Here's modeling here. This is the modeling. Here's modeling in the feet too. Sorry, these pictures aren't the greatest, but when you blow them up, they look like crap. Okay. Dyspnea, okay, a complaint of dyspnea. You may hear wheezing because of the bronchoconstriction and the swelling in the bronchial mucosa. Rhonchi is going to be an indication that you got that mucus. Rhonchi sounds like snoring when you listen to the chest with a stethoscope, and that's going to be an indication that that's that mucus that's plugging those bigger airways. Tachypnea, obviously because of the bronchospasm, the hypoxia. Cough, it's going to be a non-productive cough, but these people are going to cough and cough and cough. And when they're coughing, it's telling you that they got mucus in there. Okay, they got mucus they're trying to cough up. Tachycardia, that's typically associated with the hypoxia and the hypotension. Dysrhythmias are typically associated with some of the chemical mediators that are actually causing the dysrhythmias to occur directly from the chemical mediator. And the hypotension primarily is being caused by the vasodilation. Okay, and if they have hypotension, then it's called anaphylactic shock. If they don't have hypotension, I mean, it's like, who really cares? But a lot of people say, well, it's anaphylactic shock. Say, well, what was their blood pressure? Well, their blood pressure was okay. When you have a problem with their pressure, we had a problem with their larynx, we had a problem with their bronchial. Well, it wasn't anaphylactic shock. Shock is if the systolic pressure drops below 90, then it's considered anaphylactic shock. And then that's when you're going to treat aggressively with volume. Okay. If their blood pressure is normal, they don't need volume. If their blood pressure is above 90, they need 2 IVs, large bore, because they can crash. They could go from not being hypotensive to being hypotensive in 30 seconds. You still need 2 large bore IVs of normal saline lactating ringers, but you're going to run them TKO until they become hypotensive. Okay, again, they may end up in pulmonary edema because of the pulmonary hypertension, along with also the increase in capillary permeability and then myocardial depressant factors causing a decrease in contractility. Abdominal cramping, this is due to an increase in capillary permeability in the gut and the colon and the small intestine. Same thing, nausea and vomiting. Some of these are stimulation of nerve endings, and a lot of this is also from an increase in capillary permeability. Why diarrhea? All of a sudden, now you increase the permeability in the colon, and now you got fluid leaking into the colon, okay? And then you got smooth muscle contraction. All of a sudden, now this patient ends up with diarrhea. Chest tightness could be from the bronchospasm. Incontinence, it's usually bladder incontinence because they're already having diarrhea, bladder incontinence. And the reason why they have bladder incontinence is because you have smooth muscle contraction. So all of a sudden, the urinary bladder is smooth muscle. It contracts. All of a sudden, they have urinary incontinence. Women sometimes will complain of uterine contractions too from the smooth muscle. Conjunctivitis is usually the redness here that you're going to see at the conjunctiva, and that's from an increase in vasodilation. Sneezing, ocular itching, tearing, these are all nerve ending stimulations. Altered mental status could be from the hypoxia, could be from the decrease in perfusion to the brain. And these people a lot of times have a sense of impending doom. They're like, man, I'm not going to make it. I'm going to die. And unfortunately, a lot of these people do if you can't get them turned around. Okay, so signs and symptoms. Again, we already said this. A lot of these don't involve skin signs and symptoms, especially if it's a food allergy. Okay, if it is a food allergy, they might have the itching, oral itching in their mouth, and abdominal cramping, and the nausea, vomiting, and the diarrhea. Okay, that's what you're going to see a lot of times with the food-induced anaphylaxis. Okay, so Necempso says acute onset. Okay. Treatment indicators, acute onset, we already went through this earlier, okay? Where you have the skin signs and symptoms, mucosal edema, the angioedema, you have a respiratory compromise or hypotension, one or the other, or signs of end organ dysfunction, like organ failure, or hypotension after exposure to known allergy. They're saying that's one treatment guideline, and the other is you pick two of these. Skin signs and symptoms, respiratory compromise, GI symptoms, or hypotension. You might have GI symptoms and hypotension, absolutely no skin signs, no respiratory compromise. You're still going to treat them with what? Still going to treat them with epinephrine, okay? Because these skin signs and symptoms and GI symptoms are still being produced by an increase in capillary permeability, smooth muscle contraction, and so forth. Okay, we already talked about that. Non-anaphylactic, signs one organ, okay? All right, the main thing is get rid of these. If you could reverse these, your patient is going to survive. If you could get rid of the capillary permeability, reverse the vasodilation, fill the space to increase the pressure, reverse the bronchoconstriction, decrease mucus secretion, then your patient should survive, okay? Because by doing that, you're going to eliminate the hypoxia, you're going to eliminate the hypotension and the poor perfusion. Airway, consider epinephrine administration prior to aggressive airway management. Early intubation is the key, though. Have it ready to go. But again, try to get your epinephrine on board as quickly as possible to reduce that capillary permeability, eliminate the laryngeal edema. Okay, and the only way you're going to get rid of that is through epinephrine, through the alpha effects. Make sure they have an adequate alveolar ventilation. Put them on an arm rebreather, maximize oxygenation in these patients. If they have an adequate tidal volume and rate. If they don't have an adequate tidal volume and rate, bag them. 10 to 12, do not hyperventilate these people. They're going to have air trapping already because of the bronchial constriction. Do not hyperventilate them. If you hyperventilate them, you're going to ruin you're going to lower their cardiac output and lower their blood pressure, lower their coronary artery perfusion and cerebral artery perfusion. Do not hyperventilate these patients. Controlled ventilation, adult patients, 10 to 12. Pediatric patients, you'll do 15 to 20. Maximize your O2. You might have to disable the pop-off because they're going to have high airway resistance. Okay, fill the space. If they are hypotensive, fill the space. 2 large bore IVs, 14 gauges, running wide open. 500 ml bowls for adult may need 1 to 2 liters. 20 mLs per kilogram for a pediatric. Adult and pediatrics up to 60 mLs per kilogram if they're in cardiovascular collapse. This is not your number one treatment, though. This is not your number one treatment. The first thing you want to do is get that epinephrine on board. If it's a true anaphylactic or anaphylactoid reaction, you want to get the epi on board. But if they are in a cardiovascular collapse, you do want to give them volume. The stings, don't even worry about it. If they're in anaphylactic shock, who gives a shit about the sting? Seriously. Don't even worry about it, you know. Monitor SpO2, monitor end-tidal CO2. If it's local reaction, you know, you might want to give them Benadryl. You might want to give them breathing treatment if they have some. Focus on what the organ system is. If it's not an anaphylactic reaction, remember, if you have two of those organ systems, it's anaphylaxis. And they're treated with epinephrine. They're treated with Benadryl. They're treated with fluids if they're hypotensive and so forth. So, okay. So we already know this. We already did that. Why epinephrine? We already said. Alpha-1 is going to reduce the increase in capillary permeability. It's going to tighten up the vessel, get rid of the capillary permeability. Beta 1 is a side effect. Beta 2 is going to bronchodilate. Those bronchioles that are constricted, it's going to dilate them, hopefully open them up, make it easier for this patient to breathe, move more O2. Beta 1 is a true side effect. Alpha 2, it works with alpha 1 in the vasoconstriction. Beta 1 is a side effect. We don't want it. We don't need it. Matter of fact, the beta 1 may actually cause the patient to truly suffer a heart attack because you're increasing the the speed of conduction, the contractility, and the force of contraction and the heart rate. It's a side effect, but you have no other drug that's any better. And also with epinephrine, it reduces histamine release too. But keep in mind, there's all those other chemical mediators. If you have a patient over 50, use with caution. But in anaphylaxis or anaphylactoid reaction, there is no contraindication to the administration of epinephrine. None. Use with caution in these patients. Here's your doses. 0.3. They really recommend that you go with the low dose, 0.3. You low dose them, 1 to 1,000. And you give it in the thigh, you give it in the arm. We're not giving sub-Q because the perfusion is so bad. Okay, so you're giving it as a deep IM, 1.5-inch needle. And again, they do prefer that it's, and a lot of literature prefers that you give the 0.3 over the 0.5 because you can redose them. Pediatric patient using the 0.01 milligram per kilogram. Auto injectors greater than 66 pounds, you're going to use the adult injector. Less than 66 pounds, you're going to use the 0.15 junior injector. Okay, and you can nebulize if you have a patient that you can't fix the stridor. You gave them an IM injection of epinephrine. You may have fixed the bronchospasm. You may have turned the pressure around, but you still got the stridor. You can't reverse the stridor. That's when you're going to consider nebulizing the epinephrine. Okay, 0.5 mLs, 0.5 milligrams, 1 to 1,000, diluted with 2.5 mLs normal saline, and you're going to nebulize it and hopefully get that alpha topically deposited. Okay, you can repeat the IM epinephrine every 5 to 15 minutes if hypotension and anaphylaxis persist. Okay, cardiovascular collapse, you can start an epinephrine infusion, 1 milligram, 1 to 1,000, 1,000 mLs normal saline, infuse at 0.5 mics per kilogram per minute, titrate to the response, titrate to the blood pressure. Make sure you have an uncontaminated IV line, and if this cardiovascular collapse, you have at least another IV line that's running normal saline or lactator ringers wide open. Okay. So what you're going to do in the anaphylactic patient, the first thing is you're going to give them the epinephrine IM. You're going to then follow it with Benadryl because Benadryl is the H1 blocker. It's going to block the histamine receptor sites. I mean, histamine is still going to be out there. What the Benadryl is going to do, though, if this is the histamine receptor site, it's going to block the histamine receptor site, so the histamine is just going to go by it and it can't trigger it. And if you can't trigger it, you don't get the effect of the histamine. 1 milligram per kilogram is a recommended dose, max dose 50 milligrams IV over 3 minutes. You're giving this IV, you're not giving an IM, you're not giving it any other way. You want this IV because you want it to have a rapid reaction. And then some systems carry cimetidine, famotidine, ranitidine. They're H2 blockers. Follow your orders, whatever it is, Tagamet, Pepcid, Flucid, Zantac. Laryngeal edema, again, manipulate the neck and jaw. Okay, thrust the chin forward. By thrusting the chin forward, you're going to lift that epiglottis up, and you may actually create a little bit more of an airway. And again, you could either, if you have racemic epi, your orders may say to nebulize racemic epi. This is just a form of nebulized epi, or you could nebulize regular epi. Considering needle jet insufflation, this is only if you can't get your patient intubated. Again, remember, you're going to have to use an endotracheal tube size that might be 2 or 3 sizes smaller than what you would normally intubate the patient. If your patient, now you turn them around, but they have persistent bronchospasm, continue to wheeze, continue to wheeze, continue to wheeze, you could consider nebulized albuterol, ipratropium bromide in conjunction with albuterol could be used. Ipratropium bromide, remember, is an anticholinergic, so it works totally different than the albuterol. Albuterol is a beta 2 specific, so keep that in mind. Do not use the nasal spray or MDI. Okay, here's your albuterol. Here's your ipratropium bromide. Okay, nebulize, and again, even so, you can nebulize epinephrine if you don't have albuterol for some reason. I don't know why. you can nebulize epinephrine too, because you're going to get the beta 2 effects from the epinephrine. So if you have a patient with bronchospasm and still laryngospasm, stridor and wheezing, probably the best thing you can do is nebulize the epinephrine, because you're going to get the alpha effects to actually reduce the capillary permeability, and you're going to get the beta 2 effects to bronchodilate. Do not put them in Trendelenburg position. Volume, again, if they're hypotensive, give them volume. Load them with volume if they're hypotensive. 214 gauges running wide open, and consider your vasopressors. Again, the epinephrine is going to be the primary drug of choice, the epinephrine infusion. Again, your orders might say to go ahead with a dopamine infusion. You want to get to 20 as quickly as possible. I don't know of anybody carrying Levophed, but you want to get up to 20 as quickly as possible. That's where you get your alpha effects. Glucagon. If you have a patient who is known to have taken beta blockers, okay, they're on beta blockers, or if you have a patient that you're giving the epinephrine to and they're not responding to the epinephrine, give them glucagon, okay? Because what you're suspecting this patient, now a lot of these patients, we have no idea. If you find them somewhere, you don't know what their medical history is. If you're giving the epinephrine, you give them the epinephrine, they're not responding to the epinephrine, give them 1 to 10 milligrams IV IM sub Q of, that's the max, of glucagon. You give 1 to 2 milligrams every 5 minutes until you start getting an effect, okay? Because typically what happens is patients on beta blockers, you're blocking the beta 2, and you're not able to get the effect that you want. And so you might want to consider the glucagon in this case to actually not reverse the effects of the beta blocker, but it actually takes a different pathway to cause the beta stimulation, okay? Steroids are no longer supported. There's no empiric evidence that they actually work, okay? These are the NASEMSO guidelines, okay? The only thing that I want to point out here is that, again, we used to beat in your head that, oh, they're going to have hives, they're going to have itching, they're going to have all this redness and swelling. Not true, especially with the ingested, okay? And these, again, are here. And the only thing, and Matt, Larry, if you guys want to chime in here, but you guys still have the Solumedrol in here too, whether you keep it or not. There's nothing that says it does any harm. They just have no evidence that says it actually does any good either. So that's why they're recommending it be taken out. So, and that's it. At this point, I need beer. Okay, any questions? 9:06. Damn it. Just trying to get done on time.
Yeah, the Solumedrol is left in because of the evidence. It's been in there, and that's one of the things that the physicians have said that let's go ahead and just keep that in there for right now. So when we compare different protocols and talk to medical directors and the ASAP, American College of Emergency Physicians, the consensus was to keep the steroid in until more evidence was against it. So that's why we kept it.
Yeah, I was shocked, Larry, that NASEMSO took it out. I was actually really shocked, but.
Yeah, Al Ravosky, you have your hand up.
Yeah, in recent years, I remember hearing, we get a patient that's like in shock, that kind of diluting them down with a bunch of fluid is kind of not what you want to do because they actually need blood. Is that not the same for animals?
No, this is totally different, because here's the difference here. In a hypovolemic shock patient, their blood is outside of their vascular space. It's on the ground, it's in their belly, it's in their chest, wherever. They lost blood. In the anaphylactic patient, their blood, their red blood cells, their plasma, well, the albumin and so forth, it's still within the vascular space. What happened was, in the patient in anaphylaxis, the primary reason why they're hypotensive is you took their vessel was this size and you made it huge. You dilated it, so you no longer have. So here's an example. So whoever asked the question, are you a firefighter by chance?
Yep.
Okay. So if I took a hose line, okay, coming off of a pump, and it's a 1.5-inch hose line coming off a pump, and some new rookie takes and puts a 5-inch hose line on the end of that 1.5, what's going to happen? The water is just going to kind of like flow out of it. You're going to have no pressure because the size of that hose is too big for the volume that you can feed it, right? And so you don't have enough pressure. And you say, well, okay, so what do I need to do to increase the pressure? I got to either put more volume in that 5-inch hose, or I got to take that 5-inch off and put 1.5-inch hose line on there. So it's the same thing with the body. You haven't lost any blood. What you lost was the fluid portion. The fluid portion, about 95% of the plasma volume is actually water. You're losing the water, but you're retaining the formed elements like the red blood cells, white blood cells. So you still have all the oxygen carrying capability of the blood. But what you need to do now is you need to distribute it. So what you want to do is fill that space. So in the anaphylaxis, because they haven't lost blood, you actually want to now take that. You want to infuse a large amount of fluid to fill the space to get the pressure up, and then give a drug to constrict the space, which that's going to be your epinephrine IM injection too. So yeah, you are absolutely correct. You don't want to push fluids on a trauma patient who's hypotensive due to blood loss, because all you're going to do is you're going to increase the pressure and they're going to bleed faster. You're going to hemodilute the blood that's already in there, and they're going to bleed faster. So no, you don't want to do that. Absolutely correct. But in this case, they have no blood loss, so you want to go ahead and push volume. And if this is a case where you're going to push volume, you're going to leave these running wide open to increase that pressure.
Thank you.
Yes, sir. Anything else? Ralph likes my shirt, my Johnny Cash shirt. That's my man.
I think Chief Hutchinson had a question he posed in the chat.
Oh, yeah, Hutch.
Just have it listed there. Tagamet for ingestion reactions.
Mm-hmm.
Have you ever heard of that?
I have not. No.
Our previous medical director ordered that, and I know anytime we had a patient on bypass longer than an hour, normally the doctor would turn around and say, after you started rewarming them, give it Tagamet for the H2 blocker.
Yeah. Yeah, and this is and the reason why they're using Tagamet in this case, and this is kind of like a third, fourth line drug. If you don't carry Tagamet or any of the other H2 blockers, or like, it's not a big deal. The main thing is you want to block the H1, which is the Benadryl. But yeah, I've never heard of that, Hutch. I'd never heard of that. But the reason why they're doing the Tagamet in this case is for the H2 receptor blocker, which you're still getting some of the vasodilation and stuff from, although it's in the gut, but they're located other places. But no, I never heard of that before.
Yeah, they're just trying to reduce the acid, release in the stomach and that for whatever they're reacting to. Okay.
Yeah. But in this case, it's totally opposite. They could care less about the gastric acid. This is actually try to reverse any of the bronchospasm or the smooth muscle contraction, capillary permeability.
Right.
Results. Mm-hmm. You guys carry Tagamet, don't you, Hutch? I know you guys.
We used to, yeah.
Okay, so I knew you were one of the few that did. All right. Anything else? You can give.
The only thing I would say is be early with your EpiPen if you are giving it, or your Epi, especially if somebody's breaking out in hives and they have a scratchiness through their throat. Hit them with the Epi, because that's going to prevent severe long-term, an airway compromise, and they can usually use the Epi a lot more than waiting until they actually go into respiratory distress, and that's big. And for the H2 receptors, it's purely like an acid thing. Research shows that Benadryl is actually, or the H1 blockers are actually better for anaphylaxis than H2s. So if you did have, food ingestion, maybe the H2, the Tagamet would be good, because you would stop the digestion process. But if they are, like, if it's a peanut allergy, it's anaphylaxis, you should have the H1, so the Benadryl, and that's why we kept that in there. But give the Epi early. If anybody has any sort of like scratchiness in their throats and they feel that it's going up, hit them early with that. That's actually one of the skills that Ohio is going to add when they have their own state skills requirement. The National Registry is looking to take away skills, and Ohio is going to put their own in. And they find that EMTs and even paramedics are not quick to preemptively give the Epi when needed, and they're waiting. And by the time the patient has wheezes or respiratory or airway compromise, it's kind of late. So if you have any scratchiness or they have a weird feeling in their throat, go ahead and give it.
That's interesting too, is when the SEMSO, there's some of the stuff that they were talking about was actually doing prophylactic loading with epinephrine. Like if you get on the scene of a patient was stung by a bee, and they say, hey, look, I got this I've had an anaphylactic reaction to a bee sting before, and but again, keep in mind it doesn't matter. Those IgE antibodies can leave. That's another thing I want to point out too is like in the IgE sensitized patient, that so when those antibodies are produced and they attach to the mast cells and basophils, they can stay attached for seconds, they can stay attached for minutes, hours, days, months, or years. You might get sensitized, and within 5 seconds, those antibodies leave the mast cells and basophils. You're no longer sensitized. But one thing they did point out, they really didn't recommend it though, was that preload with epinephrine, like in the case like you're saying, Larry, it's like, oh, this person, they're allergic to a bee sting and they got stung by a bee, and there's no evidence to really say preloading is really going to do anything. But I do want to point out what Larry's saying, those, keep in mind, you only need 2 of those. If you have hives, itching, okay, and you got wheezing, they get epinephrine. If you got, abdominal cramping and nausea and vomiting and wheezing, they get epinephrine. If you got a low blood pressure and hives and itching and no wheezing, they get epinephrine. So keep in mind, look at that list of 4 things, any 2 of those, and they're getting epinephrine. I couldn't agree with Larry more. Get the epinephrine on board. I'm telling you, because that is going to reverse those pathologic conditions, and that's what's going to actually keep this patient from dying. If you want your patient to die, delay the epinephrine. Benadryl, hey, whenever, Tagamet, if you ever get to it, you get to it. The key here is absolutely epinephrine. And I see Larry responded. It's interesting, but yeah, Tom, I was going to ask you, get to that for a second, but Larry responded to Anthony. I didn't see the original one, but a lot of basic EMTs now, I'm sorry, I call them basic EMTs. A lot of EMTs now, are no longer carrying the epi-auto injectors because of the cost. And so what they're actually carrying is they're either carrying a multi-dose vial or they're carrying an ampule where they're drawing it up and they're actually administering it. And that's actually not a bad thing because, again, because of the biphasic reactions, a lot of the places they've gotten away from the epi-auto injectors, and the EMT nows they're drawing up a multi-dose vial. So that way, if there is a biphasic reaction, they have the ability to give another IM injection. So yeah, the epi-auto injectors have kind of, there are actually EMS systems that were making anaphylactic kits for the public. Because you guys remember, I don't know what they are now, but when those EpiPens went from like $60 to $600, and when that happened, there were EMS systems that are actually, they were making anaphylactic kits and they were handing them out to the public, which are tuberculin syringe and epinephrine and so forth. So Tom, go ahead, Tom. Tom, I know that it's your daughter, I believe, that has the insulin pump. Go ahead. We want you to tell us a little bit. I don't really want to take too much time, but I think people are interested in hearing what you have to say about it because you deal with it.
Tom's actually in-house at Trumbull today, so he's going to speak from my computer.
Oh.
The insulin pumps, Medtronic and Tandem, both have a screw-in connection at the pump site where the insulin attaches, and it works off of a plunger system inside of there. So anytime that you mess with that vial, there is a huge potential to unintentionally deliver more insulin through the tubing. So make sure that when you're disconnecting that, you are disconnecting at the skin, whether it be the abdomen, the arms, the legs, or the buttocks region. And Larry's going to show like a picture real quick.
I think the key too with this, and as Tom obviously is experienced with this, is rely on the family too. If there's a family member there, they know how this stuff works. And instead of trying to figure it out, rely on the family too, unless you really know.
And I will say that most pumps nowadays are very simple, easy to get into. Every pump that I've went through and learned about, whether it be Omnipod, Tandem, or Medtronic, the suspend delivery feature is on the first screen that you come across. So you just scroll down that menu, it says suspend delivery, it'll pop up, and then you can just unscrew that tube, or there's usually 2 clips on the side. Omnipod, you're just going to suspend delivery and leave it on the skin because that's actually a tubeless system. Tandem and Medtronic are the are the two main tube systems there. But like that one there, Medtronic, there's two blue lines, you just twist it with the things on the side and it just pops right off.
Yeah.
So.
Yep. And again, I can't tell you if unless you're familiar with it, ask a family member, because I'm sure they're familiar with it. So, okay, anything else? Okay. Let me ask you this real quick. This is kind of a little bit off topic, but how many of you, I don't know, Larry, how can we do this, or Matt? The question about the EMS instructor. How many of you are, I guess you could raise your hand, are EMS instructors who need 6 hours of instructor continuing ed coming up here fairly quickly? Will, Jeff, Ed, Connor. Okay, so we're getting quite a few people. Okay, okay. So we, I don't want to take up more time tonight, but I sent Larry and Matt an email, and I'd be happy to do a 6 hour and get people. And I think we need 6 hours of continuing ed, and that's for our entire 3-year cycle. So I would like to do that quickly too. And if Matt would be gracious enough to host it through TMH, we could do a joint. Again, we're talking about a free 6 hour continuing ed for the instructors. So anybody who has their instructor certification. I wanted to gear it more though on EMS. I wanted to talk a lot about accreditation issues and stuff too, the COAMSP accreditation issues. I'm doing a lecture on item writing and stuff. We can mix it up a little bit. We could do more like discussion and stuff. It's going to be a much smaller group, but so I'd like to put something together here coming up, fairly quickly, like obviously when this is done, but we could do it like in 2 nights, 1 week, do a 3 hour, and next week do a 3 hour, maybe we'll just keep it on a Tuesday and Thursday, or a Tuesday and a Tuesday, or whatever. But, Matt, if you want to talk about it, but again, we would need a platform, and if you'd be gracious enough to host it again, I'll come up with the speakers, and I'll come up with the topics and everything, and don't forget you guys have to do your teaching time too. But okay, so some Appendix G, absolutely. Appendix G is gone. Well, that's what I wanted. We do have a new student minimum competency, and that's why I don't want to leave out the firefighters. Firefighters are welcome to join too, who firefighter instructors, but I really want to focus much more on the EMS program directors. Yeah, we have a whole new. Matter of fact, that was one of my projects that I just finished, and we just passed it through, and it's actually been approved by the board at our last board meeting. And yeah, so okay, well, we'll put something together. We got enough people, we'll get something together. So hopefully, Matt, you're willing to do that, and we can move forward with that too. So all right,
Absolutely, that's not a problem at all.
Okay,
No,
thanks,
I
Matt.
appreciate you dedicating yourself like that, Joe.
Yeah, no problem. Well, I said we need it, and I could draw some people in too. So, but I would like to focus on the COA stuff. I sit on the COA MSP board. I've been on the board for about 20 years and real active. And again, just finished all that. We could spend 6 hours on the student minimum competency itself, but it's actually a lot easier. So, instead of pulling your hair out with Appendix G, this is a lot easier. So, and I'd like to spend some time on it. All right, I'll talk to Matt and Larry. We'll get it together. We'll get you guys notified. So, all right, I'm done. Beer time.
Awesome. Thanks a lot, Joe. I see that we've lost some people as the discussion goes on, and that's fine with everybody. I just want everyone to know that at the end, when we're having this discussion, although I find them very useful myself, it's kind of my favorite part. You don't have to stay. You don't have to stay for the discussion, till 9:30 or whatever if you don't want to. That's fine. But I encourage it because I get a lot out of the discussion myself. So I thank anybody who does take the time to hang out. But if you can't, we understand that. So I guess that's that for tonight. We will see everybody Thursday.
All right, sounds good.
Thursday,
Everybody, have a good
6
evening.
o'clock.
Yep. And
Thanks,
Matt and Larry will
everybody.
talk.
What's that, Joe?
I said we'll talk.
Yeah, no, we can
Yeah.
get that done easy.
Yeah, that's 2 days. So yeah. Okay, sounds good. All right.
Again, Joe.
All righty.